So good morning, everyone. Am I calling this meeting to order?
Good morning.
Oh,
Thank
there she is. Thank you.
you. Hi. This is Carol DeAndres. We're going to wait a couple of minutes to let our attendees log on and get settled. Our numbers are going up. Okay. And I believe, yes, all of our online committee members have changed their name. So thank you so much. Let's get started. Next slide, please. Good morning. I am Carol DeAndres, and I am the stakeholder and public engagement manager for the Master Plan for Aging here at the California Department of Aging, and I'm happy to be with you. Today is May 9th, 2024, and this is the California Health and Human Services Agency, or CalHHS. This is CalHHS's Alzheimer's Disease and Related Disorders Advisory Committee. This is the second meeting of 2024 for this committee. Thank you so much. So let's move to the next slide. And here are a few meeting logistics for you. Here's a link. You can join this meeting by smartphone, tablet, or computer using this link, or you can join by phone. Also, if you were in Sacramento on Gateway Drive, you could attend in person. This is a hybrid meeting. We provide American Sign Language, as you can see, and we thank our interpreters very much for their expertise in joining us today. You also have closed captioning available through the Zoom webinar functions. And after the meeting, you may find the meeting slides, the transcripts, and the recording posted to the CalHHS Alzheimer's Disease and Related Disorders webpage. Next slide, please. The chat function is enabled for committee members, the California Department of Aging staff, and other state staff or invited guests to share out meeting-related resources and information with our public participants. The public is able to view the content shared in the chat during the meeting. We invite the public to provide comments. Please hold those comments during the designated comment period. Additional public comments can be utilized in the question and answer feature of Zoom. And at any time, you are able to send an email to the California Department of Aging, to the Alzheimer's Disease and Related Disorders Advisory Committee through the Engage email box, engage@aging.ca.gov. Next slide, please. Again, public comment. We will have time on the agenda for public comment. And if you're in person in the room today, you can raise your hand and Michelle will give you the time to make your comment. Verbal comments, you can use your Zoom function, raise your hand feature, or if you're calling in by phone, press *9 and your hand will be raised and we'll unmute your line. And of course, written comments are always available through the Engage email box. And so now I will turn this over to Catherine Blakemore. Catherine, let me spotlight you. And thank you. Please go ahead.
Okay, terrific. It's so nice to see everyone. I'm going to call the meeting to order. And we're going to do our introductions just a little bit differently today because we have the pleasure very shortly of hearing from Kim McCoy-Wade, and we want to give her enough time to share her remarks with us. So I'm going to just identify you, and if you can note that you're here, that would be great. And if you want to say something else to other members, if you could just put that comment in chat, that would be wonderful. And then we will ask our new members, because we have 2 new members joining us today, to introduce themselves to all of us. So as I said, as was said, I'm Catherine Blakemore. It's my distinct pleasure to be the chair of the meeting and to do this work with all of you. And our vice chair is Dr. Wynn Canio, and I don't know if she's here. She was off potentially doing some public service communications work, I think. So Michelle might know.
She's here until 11.
Was she? Okay.
I'm here.
Hi, Wynn. Oh,
Hi.
perfect. Do you want to? Thank you. And then Barbara McClendon
Here.
and Celine Regalia
Here.
and Dr. Thompson. Not here yet, I think. I saw Julie Solier. Thanks.
Morning.
Good morning. Ken, is it Graffio? I've only met you once and I realize I don't know your last name.
Yes, it's Ken Graffio.
Graffio, perfect, thank you. Myra Garcia.
Here I am. Thank you.
Good morning. Sally Bergman.
Good morning.
I think Dr. Farias is not attending today, is that right?
Correct. She's at a conference.
Okay, and I think Todd Shetter also can't attend. And is Dr. Mobley here? Is he joining?
He is. He's currently on the participant side. We're getting him moved over to the panelists, so you can't hear him, but he's here.
Okay, fabulous. And then, I'm sorry, what?
Noted, and I will move Dr. Mobley over to the committee side.
Fabulous, thank you. And then I think our new 2 committee members might be in the actual physical location, Carlos Olivas and Claire Day, and we'd love to have you introduce yourself and we give you a big welcome. We're excited that you're able to join us.
Good morning, everybody. My name is Claire Day. I'm the Chief Program Officer with the Alzheimer's Association, Northern California, Northern Nevada chapter, and I'm delighted to be here and part of the conversation today. Carlos?
Hi, I'm Carlos Olivas. I am a primary caregiver for my dad living with Alzheimer's, and I am one of the volunteer advocates for the Alzheimer's Association, as well as other organizations around the country, and a social media content creator, spreading awareness and support for caregivers and people living with Alzheimer's.
Terrific. Thank you so much. Both really have great experience, and I'm sure you're going to enrich our conversation today and every other time we meet. So I'm happy to have you join us. I think our next item of business is that we are going to review the February minutes that were in your packet. And does anybody have any questions or comments about the minutes? Okay, is there a motion to approve the minutes? Looks like Wynn is making a motion. Is there a second? Thank you. Sally Bergman is making a second. Any other discussion about the minutes? Okay, if not, all in favor of approving the February 2024 minutes, say aye or raise your hand. Aye, great.
Aye.
Any opposition? Any abstentions? Okay, thank you for approving the minutes and welcome Dr. Mobley. I'm glad you got moved over from a participant to a member. We're always happy to have you with us. And so I think in record time, we did our introductions and approval. And what I don't know is if Kim has already joined us or not.
I don't see her yet.
Okay, so we should have been less speedy.
Maybe you can go through the agenda. And Rosie has the agenda slide she could pull up.
Okay, sure. Oh, I got to make it bigger or find my own. Well, I have my own agenda. So you can see that what we're going to do today is hear from Kim McCoy-Wade, followed by the amazing Susan Demarius, who's going to give us an update from the Department of Aging, along with whatever other staff she's including in that presentation. So we're always happy to hear about that. And then also followed by an update from the California Department of Public Health, who works collaboratively on a lot of the areas of interest that we as a committee have. And then the first part of our meeting and the bulk of our discussion today is going to focus on our recommendations for the 2025-26 master plan. So for those of you that are new to the committee, I think this is such a perfect opportunity to join us, because we will put forward 3 areas of recommendation that will be discussed at the October convening in the California for All Day. And it's really our opportunity to influence what priorities the state will have in the aging and disability space over the next 2 years. So 2 things about that. One, everyone that's on the committee is invited to participate in October. And second, it is also a time in which we will then put our recommendations forward to the full group, and ultimately the agency and the governor will approve what recommendations move forward. So exciting time, and really look forward to everyone's participation in that process. So that's going to take about 1 hour and 20 minutes, and we're doing that instead of having a sort of other kind of presentation. And then we have a legislative update, 3 great presenters about that. So look forward to that public comment period. And then, as we always do, we will finalize our recommendations and items for the secretary, and talk, just do reminders about our next meeting date. So as you can see, as we always do, we have a very full agenda, but I think one that is really important and allows this committee's voice to be heard about the direction the state will be going in the aging and Alzheimer's space. So looking forward to that. Michelle also noted that everyone can look at committee member bios, as well as, I think, the bios about our speakers. They were in the materials, but she kindly provided the link to all of that so that we will be able to use that without big introductions of other people. So lots to come.
And Catherine, just for the committee members, to keep us all in line with the Baggio-Keene Act, when we are having the discussion periods where everybody's screens are up, if you could make sure that your camera's on, and if you're having some kind of technological issue where you can't have your camera on today, or poor Wi-Fi or something, please just let us know.
Thanks for the reminder, Michelle.
And I
Okay.
don't know yet. Susan said that she's able to do her update, so maybe we can get Susan started, and then we'll just keep an eye out for Kim.
That sounds terrific. I will just note it is a very busy time in state government. I think the state budget is now being, at least I'm hearing, being released tomorrow. So I can only imagine people's hard work going on to have those discussions and get all of that information done. But Susan, we appreciate you being here, and we appreciate you kind of leading us through the updates that you have. So we'll turn it over to you.
All right, thank you. Good morning, everyone. And I'm going to switch to my notes. So just verbally interrupt me if Kim joins, in case I don't see her come on the screen, and then we'll break to her and then return to me. So good morning to everybody. I wanted to start just by thanking all the members of this committee for your work between meetings, and extend a warm welcome to our 2 new members, Carlos and Claire. As of today, all of our appointments are now filled, and this advisory committee is complete. So this is the group we get to work with, and I'm just thrilled by the membership of this group, and the conversation that's going to happen today about setting priorities for the next 2 years. I also wanted to thank Catherine and Wynn for their leadership as our chair and co-chair. And note for all of you, we are in Older Californians Month, Older Americans Month. And that's the screensaver that I have up today, highlighting the the campaign that we have out of the Department of Aging, which is Start the Conversation. And we are re-releasing our aging resources guides later this month. So they will appear in 2 million newspapers around the state and be shared digitally as well and be made available in 5 languages. So we'll make sure you all get the digital link in today's meeting. The governor also issued a proclamation at the start of the month, and we'll share that with you in the chat, commemorating Older Californians Month. So today, in my brief time with you, I wanted to catch you up on just a few items and close out with a message about the May budget revision. So when I looked back at your last meeting, we just bombarded you in the chat with lots of things. I think January was one of the busiest months we've had yet. And so you got a lot of information thrown at you at your last meeting. Today, I wanted to circle back on a few things. I wanted to remind the group that in February, the Federal Administration for Community Living issued their final rule on the Older Americans Act. And this was their first update in 35 years to the Act, their first substantive update. And we're thrilled that family caregivers are now recognized and included as a target audience for the Older Americans Act, explicitly named throughout the Act. This new federal rule, coupled with the report that the department issued, the California 2030 report, we spoke to that last time when we met. So the findings from the California 2030 report, Secretary Galley's Health and Human Services program priorities, and this new federal rule, they all led to the introduction of Senate Bill 1249, authored by Senator Roth out of Riverside County. So we are now closely following Senate Bill 1249. It has passed out of 2 committees and is being heard on the Senate floor sometime in the next week or 2. The Department of Aging is providing intensive technical assistance to the Commission on Aging. They are the bill's sponsors, and they were part of the California 2030 Steering Committee. The purpose of this bill, Senate Bill 1249, is to help steward through the policy changes needed to strengthen the aging network for the future. So it's a reminder in these bleak budget times that there are still policy changes that are needed. And we're really excited about working with Senator Roth, the Commission on Aging, and the California Association of Area Agencies on Aging. And it looks like Kim has joined us now, so I'm going to pause right here and turn it over to Kim McCoy-Wade, the Governor's Senior Advisor on Aging, Disability, and Alzheimer's. Welcome, Kim.
Thank you, Director Damaris. And I really, I'm off. And I'm really appreciate the flexibility. As you know, it's a busy time in advocacy season and in the governor's office. I did want to stop by just briefly, and Susan, as always, we didn't coordinate, but we're going to say very similar things. But I wanted to give a little preview to this group in particular, that with the launch of the terrific, fabulous Take on Alzheimer's public awareness campaign that I don't know about you, but I'm seeing everywhere. We really have taken action together on all of the Alzheimer's Task Force recommendations. We are not done, but we said we were going to do something that was the governor's one of his first promises in the state after his father died and he was elected. And 5 years later, we can say we heard you and we did it. So little preview that you should be seeing probably next week. And we'll reach out to some of you to help us coordinate and amplify all the ways that California is leading. But that gets to the second part. Now, what are we going to do together? And as Susan says, and as I can't preview what's going to happen the next few days as the budget rolls out, but as you all know, it's going to be our first tough budget in several years after 3 years of record investments. It's a different season. And so we will need to navigate and weather that together. And also, as I was delighted to meet with the Alzheimer's Association earlier this week, and talk about those other 3 levers that Susan, you just started to say brilliantly. The policy levers, whether we want to look at banking exploitation, whether we want to look at wandering, whether we want to look at embedding dementia training and data in our broader health and prevention and family caregiving systems. There's plenty of policy work to do, and we'd love to hear your priorities. There's also, as Susan knows better than me, and CDPH and agency and everybody I see around this all DHCS, all agency table, there's plenty to implement. And we need, in our remaining 2.5 years with Governor Newsom's leadership and Secretary Galley's leadership, to do that, to make all the strides we can while the time we have. And that leads me to our third lever is federal opportunities. We continue to be just so lucky by Susan's leadership on the National Alzheimer's Task Force, may I? And I was delighted to be with Secretary Becerra a couple of weeks ago, who was just over the moon to hear that Sacramento, his hometown, is a blue zone and wants to get back and get engaged in our Sacramento blue zone. So we have a lot of federal opportunities, at least for the next 6 months. So let's make the most of that and be hopefully the next 4 years as well. So that's all I'll say is thank you, thank you. It's really a critical, pivotal time to say, we can make progress, historic progress. We can lead the nation when we work together and prioritize and focus and are ready when the money's there. And you know what? We can keep going when the money is not there through all the other ways we make change. So glad to be doing that with you all. Please, let's just stay close as we always do. And I just want to lift up all the tremendous work at the agency and department to keep dementia front and center on all of our work. So grateful.
And I want to just thank Kim for joining us in the midst of a really busy time. I have the pleasure of working with Kim on disability issues and aging issues. She is a wealth of information, and we are really lucky to have her as an ally in the governor's office, supporting the things we care about. So thanks for making time to be with us. And I'm sure you have to scoot off, and we certainly respect that. But
yes, and I hope to be hearing from you all very soon, matter of hours, about what you like and don't like and what we can keep on working together. So onward. Thank you.
We're not a shy group, don't worry.
I'm counting on it. I'm counting on it.
Thank you.
All. All the
Take
best.
care, Kim. Bye. Okay. Susan, I think that means
Great.
we're back to you.
Okay, yes. So I was talking about Senate Bill 1249, and really underpinning this legislative effort is the well-known fact that demographics have changed dramatically in the past 50 years when the network was first established, and the trend continues towards more older adults, much older population, increased diversity in medical complexity, and higher rates of Alzheimer's and dementia. So we will be offering a webinar at the end of this month as sort of a tutorial on how the network was formed and how it functions today, as a foundational piece of this bill. Second, I want to remind all of you of the invaluable resources in the IHSS Career Pathways and CalGROWS initiatives. These continue deep into the fall, and we could really use your help promoting these resources and getting this training and stipends into the hands of the direct care workforce and helping family caregivers access what is, turning out to be just outstanding training resources, many topics on Alzheimer's and dementia. Third, we have been working closely with stakeholders to roll out round 2 of funding for the Bridge to Recovery grants to help adult day centers and PACE sites recover from the pandemic. And we expect the announcement about round 2 of funding to happen later this spring or early this summer. TBD, we're on top of that and just following closely with the budget, the sequencing of the budget. Fourth, we're very excited to be moving forward on the next phase of our long-term services and supports financing initiative to identify solutions for the missing middle population. We know so many families living with Alzheimer's find themselves caught between Medicaid and Medicare, facing out-of-pocket costs for their care. And later this summer, we'll start the public-facing work with our outstanding contractors on this effort, led by UMass Boston and ATI. Sarah Steenhausen, who's on this call now, is leading that effort for the Health and Human Services Agency. So you'll be hearing more about that I know that's a hot topic for all of you. And then fifth, we're just thrilled by the passage of Proposition 1 and the modernization of the Mental Health Services Act. This has been a topic of focus and discussion for this advisory committee for over a decade. And we're just thrilled that there is now a new opportunity and a new opening for older adult mental health and for the co-occurring conditions of Alzheimer's, dementia, and behavioral health. So we're working to prepare materials to educate our network on what this means for them, and also how can we influence the work ahead and draw down the funding that's being made available. So more to come on that. We've got some time with the implementation dates, but you'll be seeing quite a bit more, and hopefully we can come to you at your next meeting with much more detailed information. And then Kim touched on this, but I'll close with a cautionary note about the state budget. Over the next several days, it will start tomorrow with the governor's press conference and officially be released early next week. You'll see details on the governor's proposed May budget revision, and we are anticipating budget reductions across programs and services that our population relies on. So this advisory committee is so crucial. You exemplify that Alzheimer's, dementia, and caregiving don't sit in one program or one department or even one agency. You're one of the few groups that has this 30,000-foot view over all the work that's happening in state government. So I urge each of you to pay close attention to budget proceedings going forward, and to use your voices individually, collectively, and as an advisory group to amplify the experience of Californians living with dementia. Most of you know, as I look at the screen, you know more than me in many cases, but I will remind you, the final budget isn't decided until mid-June. The May revision is not the final budget, and what is ultimately signed into law is a collaborative effort between the legislature, the governor, and the administration. So we really count on you to be vocal and visible in the next month or so to make sure that the legislature and the administration hear from you on anything that's of significance to you. So I'll end there and turn it back to Catherine. I'm also happy to take any questions if you've.
So not surprisingly, I'm going to ask you, I have 3 questions for you. And then we have enough time, so we're really fortunate that way to see if other people have questions. The first is, I know there's these great training materials for workforce development, including supportive caregivers. And are those, even though that the funding for the stipends, et cetera, may end, is it a correct assumption that those materials will continue to live online somewhere so that people can still access them, and maybe we could have a link to them just as a reminder for people? Is that accurate, Susan, that they'll continue to be?
Yes, Sarah, do you want it? We've got Sarah for
Oh,
2
sorry,
more
sorry,
minutes.
Sarah. I'm
Sarah,
sorry.
do you
I
want
didn't see you
to
pop up.
respond to that? If not, I.
Oh, yeah, absolutely. That's why I raised my hand. Thank you for that question. It's a great question, Catherine. It's great to see everyone. So two considerations. The CalGROWS program is the training and stipend and incentive programs for the non-IHSS workforce, including family caregivers. Career Pathways is the IHSS training and stipends program for IHSS workers. However, we are working closely with DSS across our initiatives. What I will say about the curriculum is for the CalGROWS program, we built into our contracts with all of our grantees. For those grantees that actually developed their own curriculum, while they own the curriculum, we will be able to disseminate it for other broader public use after the program ends. So we're really excited to be able to continue kind of as a long-term approach to sustainability, to at least make those curriculum available. For the IHSS Career Pathways program, it's a little more complicated, but we are working with not only the Career Pathways program, but also our partners at HCI who are leading the Care for All program. which is another workforce, HCBS workforce development program, as well as Leading Ages Gateway In program. So we're trying to kind of think through broader sustainability and how we might make sure that these resources can be available to people in the community, even when the program ends. So we'll have more information on that and how we make it available for the CalGrows program and all of that. But just to note that we agree it's really important to have that available.
Thanks, Sarah. And I think my next question will be for you too. Your hand actually blends right into the map of California. So apologies for not seeing you there.
No problem.
So Susan mentioned that you were the person taking the lead on the long-term services and support sort of benefit that you have a contractor for. And I'm just hoping that we could add a discussion with the contractor about that program at an upcoming, sometime this year.
Absolutely.
Discussion, because I think it's kind of front and center of much of what this committee has talked about. How do we support people who are kind of in that forgotten middle? So just flagging that,
Yes,
that would be a fabulous opportunity for.
absolutely.
Thank you.
Just to give for the committee's reference, this is a $5 million initiative that we're really excited to be embarking on, broadly speaking, to look at policy options for long-term services and supports financing and affordability. It's kind of a multi-pronged approach. We're working with the LTSS Center at UMass Boston, led by Mark Cohen. We're also working with Community Catalysts and other vendors such as ATI Strategies. It's kind of a multi-pronged approach, but one of which will be a population analysis of the needs now and projected into the future for LTSS and what that could mean for our system. Also doing kind of a landscape analysis of policy opportunities across Medi-Cal, Medicare, other sources that may be good practices for California to consider. And then also what we're really excited about right now is we're working on a potential pilot demonstration proposal for consideration with the Federal Center for Medicare and Medicaid Innovation that would look at the feasibility of launching a demonstration to test a Medicare home and community-based services, some sort of a flexible benefit in Medicare. So lots of information forthcoming. Of course, all of this is just concepts that we're exploring right now, but we look forward to briefing the committee once we begin the kind of public stakeholder process and once we have more information.
Okay, thanks. And my last question is probably to Susan. Really appreciate your comments about the budget and the role individuals in this committee can play. If you had to identify the best way for this committee to get information about what the budget says in the aging space, what would you recommend?
Good question, Catherine. I'll share in the chat the Department of Finance, their summary. It will all be released. I believe it won't be released until probably early next week, the full detail. But these are lengthy documents, but they're very easy they're categorized very well. So you can move to my point, you don't just look at the Department of Aging, you look, for people with Alzheimer's and dementia and family caregivers, it's Department of Healthcare Services, Social Services. But I'll make sure everyone has links for that. And we try to get it out through our stakeholder listserv too. So I hope everybody on this group is part of our listserv, and I'll share that link too to make sure everyone is registered to get CDA updates.
Okay, thank you for that. So I asked more than my share of questions, and we still have a couple minutes left. So if Susan doesn't mind other questions and someone has them, please ask away. And it looks like Barbara has a question or two.
Hi, Susan.
Hi.
Just fun.
Hi, good morning, Barbara.
Good morning. So Kim mentioned this, so I'm hoping I'm asking you a question that I might have been better asked to Kim. Did she say in her beginning comments that there was going to be some kind of an update or report on those Alzheimer's recommendations, those 10 that were kind of embedded within the master plan on aging? Can you speak to that?
Yes, you heard correctly.
Okay.
We've been working just, in our we continuously update, and Julie, who's on, we have internal meetings to go through all 10 of those recommendations from the original Alzheimer's Prevention and Preparedness Task Force. And so we have done, we've completed a summary document that's under final review that will be released that shows our status and progress on all 10 fronts. So yes, something could come out as early as next week on that.
Okay, great. Thank you.
Yep.
Terrific. Thanks for that information and good question, Barbara. Others have questions for Susan. Okay, I think you are off the hook for on-the-spot questioning, but
All
you're
right.
such a great resource. We're really grateful that you were able to join us.
Thank you, Catherine. And there was one other item I forgot to mention. Last week, the National Alzheimer's Project Act Advisory Committee met for 2 days in Washington, D.C., 2 full days. And I was so proud that there were 6 presenters from California. So our distinguished academic research partners from several institutions presented. We had someone from the Department of Corrections talking about the aging prison population. We had the Dementia Care Aware program featured. We had the UCSF Care Ecosystem. We had Dr. Margot Cushell talking about the increasing rates of older adult homelessness and the co-occurrence of cognitive impairment. So, we have a stellar state. It's not going to feel that way next week. But, truly, this is, the work that you're all doing. Celine, how Compass was highlighted. So, we are leading the nation. Some days it does not feel like that. And we know we have a long way to go, but it was absolutely a point of pride. And I'm so honored that I get to serve on that group and connect our federal partners with the work that's happening in California. So keep it coming. Keep it coming.
Celine, did you have a comment or question or no?
Oh, no, sorry.
Okay.
I'm
No,
smiling. That's
that's
great.
great. Perfect. Okay. Thank you, Susan, again, for just participating and giving us such good information. And we really appreciate your availability to the committee and all of your wonderful staff that supports us. So I think we're going to turn now, just a couple minutes ahead of schedule, to the California Department of Public Health. And we have Lindley Stern with us, who's going to do an update of their work for us. So maybe we can advance the slide deck and turn it over to Lindley, who I think I saw earlier. So
I'm on. Thank you, Catherine.
Great.
Good morning, everyone. My name is Lindley Stern. I am the Chronic Disease Control Branch Chief, where the Alzheimer's Disease Program is situated. I will be outlining the work that the Alzheimer's Disease Program, or you may hear me call it ADP as the acronym throughout the presentation, does to address and advance the Master Plan for Aging. Next slide, please. The Master Plan for Aging is a guiding document for the work that the Alzheimer's Disease Program implements. Within the Master Plan for Aging, the Alzheimer's Disease Program works to address Goal 1, housing for all ages and stages, and Goal 2, which is Health Reimagined. Next slide, please. So within Goal 1, housing for all ages and stages, we address the strategy of all outdoor and community spaces for all ages. And the initiative is to promote blue zones for dementia-friendly communities, especially in cities and counties with higher proportions of racial groups and disparate rates of dementia, which we heard Kim McCoy-Wade mention earlier. Next slide, please. So focusing on the prevention of dementia within local communities, we awarded one local health department, as mentioned before, Sacramento County, $1.7 million to partner with the Blue Zones organization in a pilot project with the goal for communities, and we've outlined the 9 neighborhoods of focus, to become Blue Zone certified, meaning it optimizes the environment and develops policies that increase physical activity, healthy and whole food options, socializing, reducing smoking and alcohol abuse, while increasing volunteerism and improving mental health. This project aims to create long-term place-based interventions that support healthy behaviors, reduce health costs, extend lifespans, and improve quality of life. Becoming a Blue Zones community is a 3-phase process, and the readiness assessment is the first step. So the key deliverables of this project are to complete a Blue Zones readiness and feasibility assessment and develop a report, which has been linked in the chat, as well as developing a transformation proposal as an implementation plan to reach Blue Zone certification. The last deliverable is to develop and secure a sponsor to carry out the work to implement the transformation proposal. So Sacramento County is currently working on this final deliverable that will decide whether or not the project will continue past June 30th of 2024. Next slide, please. For Goal 2, Health Reimagined, we address 2 strategies: dementia in focus and lifelong healthy aging, across 4 initiatives that I will dive into in the next slide. Next slide, please. Under dementia in focus, we address 3 initiatives, including an equity-focused dementia prevention public health campaign, the second to target clinical research in Alzheimer's on gender and racial disparities, and 3 to replicate best practices developed as part of California Healthy Brain Initiative and Blue Zone efforts to extend statewide expertise in cultural competence, community outreach, caregiver education, workforce development, and local planning for people at risk of developing Alzheimer's, individuals with dementia, and family caregivers. So under the strategy, Lifelong Healthy Aging, we address one specific initiative, which is share a series of public health or public education tools with culturally competent and equity targeted approaches that promote brain health and address other healthy aging priorities. So next slide, please. So back in 2019, we were given the opportunity to fund community level work at 6 local health departments with a focus on policy, systems, and environmental change through the California Healthy Brain Initiative. This initiative serves to advance cognitive health as an integral component of public health and implement public health strategies that promote brain health, address dementia, and support people living with dementia and their caregivers. In order to do so, funded projects were required to implement the CDC Healthy Brain Initiative 2018 to 2023 roadmap. Our program awarded 6 California local health jurisdictions, as you can see on the map, that left column. So it's counties of Los Angeles, Placer, Sacramento, San Diego, Santa Clara, and Shasta, for a total of $4.5 million in one-time grant funding, and that was provided from 2020 to 2022. And this effort was so successful that our program received $10 million to continue funding the California Healthy Brain Initiative work in these 6 counties for another 2 years. And in addition to these existing counties, we were given funding to expand. So we expanded to 7 additional counties that you see on the map, which includes Alameda, Butte, Monterey, Orange, San Luis Obispo, Siskiyou, and Sutter counties. And they were awarded through a competitive process to expand the California Healthy Brain Initiative work through June of 2025. In 2023, the Alzheimer's disease program also was awarded $2 million over 5 years from the CDC to continue to expand the California Healthy Brain Initiative work throughout the state. The key deliverables for these California Healthy Brain Initiative counties is to conduct an Alzheimer's disease and related dementias community needs assessment, develop a strategic plan to carry out their work, and develop and engage a local coalition or advisory committee of Alzheimer's disease and related dementias, aging, and chronic disease experts to guide their work. A few counties have formally implemented an Alzheimer's disease county department, for instance, San Luis Obispo, that will continue the work of the Healthy Brain Initiative beyond this 2-year contract, which is exciting for sustainability. Next slide, please. Taking that health equity lens that, is enmeshed in the framework of the Alzheimer's disease program, the 2022 cycle of research funding had a focus on understanding and addressing the greater prevalence of dementia in women and communities of color, and also focusing on expanding research to include populations historically underrepresented in research. So that includes the LGBTQ+ and questioning community, American Indian, Alaska Native, the Native Hawaiian or other Pacific Islander, and isolated and rural communities. As an update, we recently awarded 7 projects for a 4-year funding cycle to continue expanding research among those populations. And some of these innovative projects include a Spanish language program for Latino caregivers of persons living with dementia, early dementia detection and genetic screening testing in underrepresented populations, research among California, American Indian, and Alaska Native Medicare beneficiaries, and health and long-term services needs of refugees and immigrants with dementia and their caregivers in California. Next slide, please. The Alzheimer's disease program was provided $3.4 million to fund the development of a caregiver training and certification program that will elevate the care in communities throughout California by expanding access to evidence-based dementia-related education and training for caregivers with a specific focus on unpaid family caregivers. We established 2 partnerships between Northern and Southern California with the University of California, San Francisco at Fresno and the University of California at Irvine to create the curriculum with a goal of creating 28 modules. This program acknowledges that caregiving looks different in different communities across geographic region, racial ethnic group, stage of disease, length of time of being a caregiver. Therefore, this program provides training options. 1, have an individual caregiver focus that provides a pick and play for a user based off where you're at in the caregiving journey. And a second option with a community caregiver focus of joining a cohort or community of fellow caregivers with shared experience. So to date, 22 modules have been developed and are in the process of being tested and piloted within local communities. The final videos and module guides should be available by the end of the year for distribution, and we will also be sharing them with our California Healthy Brain Initiative counties to adopt and disseminate. Next slide, please. Under Goal 2, Health Reimagine, we address the strategy of lifelong healthy aging through the initiative of sharing a series of public health, public education tools that are culturally competent and equity targeted to promote brain health and address other healthy aging priorities. And the next slide, please. So in order to communicate these important messages about Alzheimer's disease and related dementias to the public, the Alzheimer's disease program funded out $8.5 million specifically to focus on educating the public on the signs and symptoms of Alzheimer's disease and using targeted outreach to connect with populations at greater risk of developing Alzheimer's disease and related dementias. The goal of California's first Alzheimer's disease public awareness campaign is to be multilingual, multicultural, and intergenerational. It's designed to shift public perceptions and reduce social stigma. So in early December of 2022, we selected our vendor. Our media vendor is Runyon Saltzman's Inc. or RSE. And after a year of collaboration, lots of planning, we successfully launched the campaign in late January of 2024 of this year. Next slide, please. So the Take on Alzheimer's campaign, as Kim McCoy-Wayne mentioned, it aims to educate and empower all Californians to recognize the signs of Alzheimer's disease, start a conversation with friends, loved ones, or a healthcare provider around Alzheimer's disease, and learn ways to reduce risk and improve brain health before or after an Alzheimer's diagnosis. Our integrated media strategy for this campaign has incorporated paid media, which is tailoring dynamic messages through television, radio, digital, social, out-of-home, and print placements that you may have already seen in the market, and we hope that you have, as well as owned media, including the campaign website or our landing page. That is the first link on the slide that we developed and where our ads are driving the public to access more information and resources. And then public relations efforts, which includes both earned media and community outreach strategies, like hosting regional community events. We hosted one in Alameda County in partnership with our California Healthy Brain Initiative county there and the experts in the Bay Area in Oakland. It was very successful yesterday. Convening ethnic media briefings, developing bylines and op-eds for newspaper article placements, conducting ongoing earned media interviews and coverage monitoring. Our community outreach efforts also include community-based organization partnerships where we reach our target audiences and priority populations, which includes faith-based organizations. We outreach to new and existing Alzheimer's disease program community partners and local health departments, and we conduct webinars and community events. So we definitely encourage you all to learn more about the Take on Alzheimer's campaign, and it is running through June. So unfortunately it's ending soon, but please explore the links that we have listed on this slide, and they are all in the chat as well. Okay, and thank you for your time. And if you have any questions, please feel free to reach out to us. I'll put the email in the chat. It's alzheimersd@cdph.ca.gov. Thank you.
Does anyone have questions for Lindley? Yes, Dr. Mobley, go ahead.
Yeah, it's really encouraging to see, Lindley, so many programs going forward and such a lot of funding. I mean, it's extremely encouraging. Because it's research and there's real research going on, are there careful measures of efficacy? Are you going, will the Department of Public Health have direct evidence for the impact of what you're doing at the level of the individual patient and family?
That's a good question. I think as CDPH, we're definitely looking at impact and how cutting edge research really expands the field and how we're addressing Alzheimer's disease from a public health lens, and I think a bigger population lens. From a patient, from their provider perspective, no, but I would say we are hosting a virtual research symposium. So historically, the Alzheimer's disease program in CDPH, we have funded research for many years. And this is our first time to really collaborate and coalesce all the researchers together to talk about the research that's been funded, to talk about what's current or ongoing work in research, and also past work, to see kind of where we've come and where we're continuing to move in the direction of research. And that could be various fields. And I don't think it's necessarily specific patient and provider, but maybe DHCS might have more insight on that.
I'm just thinking that if we want to be a nation leading model for caring for people with Alzheimer's disease and in getting out the word about Take on Alzheimer's, it seems to me that having even a document that literally reviews all of the research that was done and lays out exactly what was accomplished could be very important, for not just for us to learn from our own engagement, but also to help other states understand what works and what doesn't work very well. For example, some things that will be used will have some impact, maybe not very much. Some will have a dramatic impact on just the lives of people living with Alzheimer's disease. So I would just encourage a very scholarly approach to understanding what these investments have produced.
I wonder if that comes out at didn't you say, Lindley, there was this research, did you use the word symposium or training or something up, and maybe you could provide information about that, or who's invited to that, because it seems like that's the ideal place to have a discussion about the topics that Dr. Mobley's raising.
Right. We're having our first symposium virtually in June, so I can share that out with the committee, the Alzheimer's Advisory Committee members. We have shared it out with our CDPH partners who will be partaking in that, and we'll continue to, we'll probably post it on our website as well. So I'll communicate those messages out as soon as the invitation and all the planning is complete.
Yeah, thanks for that. That sounds like an interesting opportunity to have kind of the discussion about the future of it. Other questions from committee members? Okay, while people are thinking, I had two questions, I think. You gave that great example of San Luis Obispo embedding kind of the work that they're doing under the grant in state government. And I wondered if we have any ideas about how other counties are working towards sustainability of that program.
That's a good question. I would have to chat with you online a little bit more about that with the Healthy Brain Initiative team about what counties are thinking, but I think we're kind of in the early stages of having that conversation and what that looks like. And I think specifically with the 6 pilot counties that originally started in 2020, they are definitely more down the pipeline in terms of implementation and their infrastructure to be able to build that. So I can definitely be in contact with you more about what that kind of looks like and how those conversations continue to evolve as we close in on 2024 and think about the next fiscal year, because I think that's more of the conversations we're going to be talking about and thinking early into the next fiscal year.
So I think that seems like a nice update for, we're always grateful you joined us. So maybe an update just about kind of sustainability kind of in a subsequent presentation would be great. Thank you. And then my second question was really about the public awareness campaign, and kind of similar to Dr. Mobley's question, is there a way in which there are metrics that sort of measure the impact of that campaign? I mean, I think there were lots of really fabulous materials. I honestly don't know that I've ever seen one anywhere, but I'm not like a big social media person or a television person. So if, that might explain why, but I'm sort of interested not just in the places it was distributed, but did people learn anything from that, right? So not just the output, but the impact on individuals' knowledge. So I don't know whether that was part of what they're doing or not, but it'd be interesting.
It definitely is. I believe at the last committee meeting, Lisa Gonzalez, who is our program lead for that campaign, had mentioned that there are 2 areas that we are evaluating at, and that is the media metrics in terms of engagement. But then also we are doing a research evaluation report to really look at what the impact is and changing attitudes and what that has been. So that is kind of an evaluation portion that we're looking at the campaign that I can definitely update the committee with after it's conducted and the campaign has closed. So probably the next meeting, it might be available.
Thanks for that. And sorry for not recalling that presentation. So that's great. Any other questions or comments?
There's a question in the Q&A. Maybe you could go in and answer
Oh,
that.
great. Yep.
You could just
Where can we find more info about the caregiver training from CDPH? Was this different from CalGrow's Caring for Cal programs?
Yes. So the caregiver training program information hasn't been released yet because the modules aren't complete. So as soon as they are, I can provide that update and provide where it will be linked for the group or where it will live, essentially virtually. And it is different from the CalGrow's and Caring for Cal program.
Fabulous. Okay. Thanks for flagging that, Michelle. I should ask too, are there any questions in the room? There is. I now see a hand. So I can't actually see you. My screen is too small, but go ahead. I see a hand. There we go. I see a big hand. Go ahead.
My question is, for the caregiver training program, how is community going to be made aware of this? Like caregivers like me, we need this information, but how do we get it? How do we see it on like social media or on TV or in print? How is it going to be utilized through like California's caregiver resources centers?
That's a great question. I think that's the next phase. Once we've completed the actual development of all the curricula and modules, then our next phase will be how do we market, how do we outreach with our CDPH partners, our online resources, our out of CDPH partners, and how do we market this? How do we reach the communities it needs to reach and our priority target population? So that's kind of the next phase in implementation of this caregiver program. Once we've actually created all the modules, we'll develop a kind of marketing and outreach plan that we can share with the group.
So thank you. And thanks, Carlos, for asking a good question. I guess I would also encourage using this group as a way to have a discussion about what would be some good distribution marketing strategies, since lots of people here have experience as a family member or provider and others. And I think we could offer some ideas about what might help increase the reach of that. And Carlos, it looked like you had I saw your hand go up. So do you have another question or comment?
About how having that discussion of how we implement awareness and sharing this resource out there, because caregivers need help, and there's one every day that's crying on support groups or in forums. So we need to have this out there and encouraging, empowering caregivers.
Absolutely, I agree.
Yeah, so maybe it's a way in which we could have a presentation about that and give some input, or To your point, if the timing doesn't work, maybe there's some way that Michelle could connect individuals who have, ideas about that to you, Lynn.
Mhm. The timing definitely should work with the next hopeful meeting, if not the next meeting, maybe the following one, because our partners need a little bit more time to develop all the modules, and then we'll be able to present it to the group and then talk about where they will live, and then our next marketing strategies, and we can talk about that. I can present that to the group as well.
That sounds great.
Mhm.
And Michelle, I'm sure, is keeping track of all of our good ideas of things that we can add to future agendas in case we didn't have enough things otherwise. So that's wonderful. Okay, I want to thank Lindley for joining us and for all the great updates that she provided and her willingness to answer questions. So thanks always for being here and being so useful and helpful, informative. So thanks so much. Okay. That is going to take us right on time. Is that miraculous or what? To the big amount of work that we have to do today. So we're going to spend the next hour and 20 minutes or so talking about our recommendations for the Master Plan for Aging initiatives. Michelle, should I just be walking through the slides? Is that what makes sense, you think?
Great.
Okay, so we're going to go to the next slide and we're going to just do a little grounding, I think, first before we get into the discussion. So at the beginning, when I was going through the agenda, I mentioned that every 2 years, California has California for All Ages and Abilities Day of Action. That is coming up on October 8th. It's going to be in Sacramento. It's a full day. I think they're figuring out kind of what does a full day mean in terms of timing. And there'll be an opportunity for all of us to register, and you will be supported if you need support in getting to the meeting. It was really a wonderful opportunity at 2 years ago for us not only to present what recommendations we had, but to listen to others in the aging and disability space about the issues that they thought were important. And I think our recommendations had influence on what the state has continued to work on. So I would just really encourage all of you to participate in the event, join us in Sacramento. And you'll see, I think, the work that we're going to do today reflected in what we are presenting at that meeting. So go to the next slide. So the point of our work today is to focus the state's future work on the highest priority issues facing Californians today and center the future planning on equity and lived experience of individuals. And I find that very heartening. Those are two values that I think are really important. Equity meaning that the plan reflects the needs of a really broad and diverse community of Californians, and that the lived experience of both individuals and their family members is really important. I'm doing some work in a different space, and one of the things I was struck by is in that group, they talked not only about lived as in past experience, but the lived and living experience, because for many of us who have provided caregiving, it is a daily living experience. So I think when we're thinking about this, to reflect about equity and lived experience. So we're that's what our focus is, and we should have that lens, I think, as we're developing our recommendations. Michelle just posted the California for All website if you want additional information. At the Day of Action, we're also going to celebrate the progress that has been made to date. I think we're lucky as committee members because we get really good reports about the initiative the state is working on. But I think there's things that happen in other spaces we may not know about. So it's a way to really bring everyone together and understand the accomplishments and the importance that the Master Plan for Aging has had in shaping the work that we're all doing. And the goal is to also engage diverse partners in this whole government approach. It's not about one department, it's about stakeholders outside of departments and all working together to lift up the needs of individual older adults and those with dementia to ensure that they're part of what California considers when it's setting its policy and budget initiatives. So help us prepare for the increasing number of aging Californians that we have and will continue to have. Okay, next slide. Okay, so when we start doing our work, these are, and we identify our priorities, we're going to be asked to really answer 4 questions, and we'll be able to pull this slide or a similar one up after we have our priorities discussion. But it's really, where are we now? And when we're setting priorities, I think it's always important to understand what the baseline is. What's happening right now? What are the unmet needs, or why is this important? And we also need to develop a problem statement. So we'll have some discussion for each of our priority areas about where are we now. We also will talk about where do we want to be. This is really our goals. So if we know where we are now and we then state where we want to be, then we'll be able to show sort of the outcome we want to achieve. We'll have to brainstorm some recommendations about how we're going to get there from where we are now to where we want to be. What are some specific recommendations and strategies? And how will we know when we got there or getting there? So how are we going to measure? To Dr. Mobley's earlier point, we should be able to measure what we're doing, and that's going to be that part of the discussion. So those are the 4 things we're going to try and think about for each of our priorities today, and move us forward. The next slide. So this is going to be a little reminder about what we've done so far. I'm really grateful for this committee because we had really good participation in 2 surveys. So Michelle was able to capture a lot of the things we have discussed over the last couple of years and pull together initiative ideas and categorize them into some broad categories. And we did a poll, what Michelle calls poll number 1, and asked you to identify the categories that were important to you. And what you said during that poll was that caregiver support is important, long-term services and supports, and access and affordability to those long-term services and supports is important. Professional training and workforce development was important, as was high quality care for community-based services. So those were the 4 priority areas that came out of the first poll. And then Michelle then put together poll 2. You can see she's been spending a lot of time helping us develop this presentation and lots of polling. So thank you, Michelle. And the second poll was really about what are the top rated ideas and where do they fall within caregiver support, long-term services and supports, community-based services, because those were the top 3. And you gave responses to each of those as well, which will then start the framing of what do we want to prioritize. So I think we'll go to the next slide. So what we have, so you Michelle is flagging that you have you got 2 documents in advance of this meeting with the prioritization materials. If you want to look at that, because there's a lot on this slide, and I'm actually going to make mine bigger so I have a better chance of reading it. High quality care, community-based services was one of the priorities that we had. The areas that rose to the top of that, and these are the things we're going to go back and we're going to come up with what are our top 3 priorities out of all of these things. The first that received the highest numbers of votes is ensure that supported decision-making and resources being developed are appropriate for those living with dementia and their supporters. The second was that we want to secure continued funding to expand initiatives that were launched with short-term funding. And there are a whole list of programs underneath that. I think we've heard about many of these at our meetings. So the list of things that we might want to consider continuing with short-term funding are access to dementia-capable, person-centered adult day services, which is called Cal Compass, workforce training and career pathways training, and there's a list of what those are. Use of community health workers to provide dementia care management through the state's aging services network, which is called CalZ Connect. And then the Alzheimer's Public Awareness Campaign and Healthy Brain Initiative sites, and our California's participation in Blue Zones. So I'm going to just pause and say one thing about this. I, of course, because I like to make a point about as many of the valuable programs as possible. So I, in my head, I like, fine, we'll just say continue to support all of these. Michelle reminded us that sadly is not really an option, that that for our recommendations to move forward, if we chose to do something in this space, we actually have to be, I told her I was sad yesterday, so I can still be sad, that we have to kind of choose which one of these we think is the most important to move forward if we were going to choose something. So it's a really lovely list and there's really important work being done. But I just feel the need to tell you, like, my creative approach to saying fund everything was not something that was going to work. And then the other one under high quality care was to identify and pursue strategies to improve collaborations and reduce silos among agencies to address the needs of people with intellectual and developmental disabilities and dementia. So I'm going to go, well, maybe I'll just ask, does anybody have any questions about what's on this slide? Because there's a lot of information there. I promise you the next are not quite as dense.
Catherine, if I could just ask quickly, so the process we're engaged in is to really come up with the absolutely most, gotta have this kind of, this activity
Very well
is
said.
actually on priority.
The most, so we get to choose up to 3. And I think, I think at the moment we have the 3 that are here. I think we have a total of 10, Michelle?
Yeah, we can.
So we're going to go through the top 10 things that came out through all the surveys that you did. And we have to choose 3 among those things, which is not going to be easy, I would think, but that nonetheless is our task. But thank you for the excellent question, Dr. Mobley. Okay, anything else about this slide? Okay, the next ones are long-term services and supports, access and affordability. I think Michelle believes we can include this entire one because we're giving options about how to achieve it. So it would say increase options to provide care to individuals with dementia through strategies such as developing and launching a long-term services and supports benefit, establishing a voluntary savings account, and or increasing slots in the assisted living waiver. So, but what there really is we need to find a way to make long-term services and supports accessible and affordable. There's a variety of strategies the state could use to achieve that, and we've given some examples of those under this one. And then the last one, which we talk about a lot at each meeting, is under the category of caregiver support. And there are 2 things here: provide financial support for caregivers, including investments in and access to affordable respite services. And the second one is incorporate family caregiving into planning and local communities to increase the availability of culturally appropriate services for caregivers. I think Michelle's wisdom is those are harder to link into one. And so I think her advice is if we choose something under caregiver support, we would need to choose one of those 2 things. So we have our work in front of us, our task, and we're not going to go through the rest of the slides. I think we're going to stop here and see if we can get some agreement about those things that we just mentioned. And so we've reviewed the top 10 priority recommendations. We have to select 3 priorities. And then once we have those 3 priorities, we're going to go and talk about those items that we talked about at the beginning. Where do we want to be and how are we going to get there? And then after that, we will choose, we'll ask for volunteers for a small group to iron out the details based on the discussion, and we'll all have a chance to look at that in August. So does it make sense to people what we're embarking on? The other thing I want to just, this is our opportunity to hear from every single committee member about what's important to them. And I really want to make sure all of our voices are heard. I think sometimes in these meetings, myself included, you can see I always have lots of questions if nobody else does. And other people have questions, but what everybody says is equally important in shaping our recommendations. And I'm really hopeful that we can reach a consensus about what are the 3 areas we want to move forward. So with that, I'm going to open it up. I think, Michelle, do they all have this list of things that they can refer to?
So in the calendar invitation, and if you don't have your calendar invitation handy, if you click on that link that I put in the chat, there are 2 documents. So one of them has kind of the pre-work that had been done, and then there's one document that just has those 10 initiatives listed. So people should be able to grab that.
So if you have, we can also always go back to the slide. Like I know particularly for the high quality care community-based services, there were a lot of things there, right? So if you don't have it and you want to go back and take a look at it, just let us know that too. And I'm pretty sure we can take slides backwards as well as forward. So we can pull those up as we need to.
The top 10, one slide that just has shorter versions.
Okay, perfect. We have one slide. Do you think it's helpful just to put that, is it possible to put that one slide up, do we think?
Okay, I want to make sure that you all can see each other for the discussion, and if we put that up, then we won't be able
Hard
to
to do it. Okay, so what are people's thoughts about the various initiatives that came out of our various polling? And do people have some thoughts about what ones we should be advancing?
Can I talk?
Please go ahead. Thank you. Thanks for, it's very hard for me to see you, so I'm grateful when you say, can I talk?
I think these top 10 impact family caregivers in whole. And it's going to be hard to choose.
I agree with you.
So what's going to be the short-term and long-term, I guess, plan or steps forward? The question, and how do we implement that? How do we make this available to the people that need to have support? Like boots on the ground right away, and how do we make this happen?
So I think you're right. And before we can get to the how do we make it happen, we have to identify out of this list of 10, the 3 things we want to focus on. So by way of example, we could say it's really important to provide financial support for caregivers, including access to affordable respite services. So people have someone else that could come into their home and provide help. But I'm not saying that's what it has to be. I'm just like, that's an example of one. So as you're thinking about that, I'm gonna let Celine and then Barbara have a moment to give their recommendations about this or their thoughts.
Well, of course, I have a bias since I was part of Cal Compass and the dementia capable adult day services program. But part of the project was really about how to disseminate and bring that work to all the centers in California. We came up with standards of care and ways that we could start. And I met with a committee some committee members that came up from sorry, I'm forgetting the committee, but they work with the IDD population, and they were interested in how we could take kind of the learnings from what we've done to that to impact all the centers. So I mean, just the ability and the family caregiver support and the caregiver education and all the things that an Alzheimer Daycare Resource Center does, we're working as a group still to figure out how we can, you know, continue our work regardless of the, you know, of the funding, but that's what where we are right now.
So if I'm understanding, you're saying a priority for you would be to continue the funding for the Cal Compass program.
Yes, because it has the potential for statewide impact to have all adult day services because of the work we've done this year. And we could share that later with the committee if there was an opportunity about what we accomplished, but it was really around creating standards of care, education, and standards for the model that we could disseminate throughout the state for adult day services beyond the people that participated in the grant.
Okay, thanks for that, Celine. Barbara.
So building on a comment that was made earlier, this list includes both initiatives that would have impact, we'd see impact more quickly, and those that would take longer. So I think I would be for kind of a balance of, you know, some of both of those. So for example, the first one that's listed on one of the pieces of information that Michelle sent out to us about increasing options to provide care to individuals, you know, through strategies such as the LTSS benefit. I was such a strong advocate for that recommendation, and I recognize that that might take a while. But if we were to put something in place that was meaningfully helpful to that big group of families who have too much, you know, income and resources to qualify for Medi-Cal and not enough to comfortably pay for any of this, and right now are just pretty much on their own. It would be amazing if California could do something like that. So I really feel like for the communities that we're advocating for, and as you know, part of being on this committee, that that should be one of them that we put forward. And then I'll echo Celine as it comes to that Cal Compass recommendation on adult daycare, because that program is so important to our families. We need so many more of those adult day programs that are dementia capable, and they're really struggling right now. It's difficult financially for them to stand, you know, they're closing all over the place when we need them to be going exactly the opposite direction. We need more of them everywhere. It's when you see a high quality program like the one that Celine is a part of, it's such an incredible resource for families. It's not just a safe place for your loved one to be where they're getting engagement and stimulation, but it is a convening space for the caregivers. So it could be one of those places in the community where it's been brought up a couple times so far. How do caregivers find out about these things? How can they get access to these resources? You had a really strong network of these programs everywhere, again, dementia capable. That could really go a long way to connecting caregivers to those resources and helping them access those programs. So I would definitely put that one up there too. And then I know there's one that's related to respite. That's also so important to family caregivers. I don't know, you could think about the daycare programs as being a source for respite. So I don't know if we would put both of those up there. It's hard to leave respite at the side though for me. And then finally, I'll just say the one that's about community health workers providing dementia care management through the state's Aging Services Network. I just think that has such potential, again, to help people across the range. Like wouldn't just be available to people who were Medi-Cal eligible. This would also be something that could be a support for people who are outside the Medi-Cal population. And I think anybody who's been on this journey can tell you how hard it is to navigate accessing services for your loved one. And so if you had someone embedded within your community, which is sort of the essence of a community health worker who could help you walk through this, that could really be transformative for families. Again, making sure that whatever is available out there, that they can that they know about it and can help them access it.
Okay, well, you have 4.
I know, but I said like respite or
I got that, but I'm just gonna, I'm not asking you to make a choice now. I'm asking you like to think about, like, if you had to choose three, like what they would be if we can't. I heard your creative suggestion about trying to merge things together. So, okay, others who want to express a preference, Dolores, thank you. Welcome.
Yeah, sure. This is such a fabulous discussion. It is really hard to narrow down, but I guess I'd like to make a pitch for the second one on the list, which is incorporate family caregiving into planning in local communities. So I think we have, the big picture with the statewide initiatives, and there are several outstanding ones here, but I think a lot gets done at the local level or doesn't get done at the local level. And local communities are so different from one another, depending on where you are in the state and what resources are available to you in that particular locale. The language, the culture, the financial, socioeconomic status, they all vary greatly, as we all know. So I guess the way I read that was incorporate family caregivers into the planning, so that not only are we looking that family caregivers themselves who might be able to volunteer, perhaps they would be former caregivers, who would have the time to be able to volunteer, who would, so that their input is heard. I didn't see that in any of the others, that we were, and I interpreted it as family caregivers, not just family caregiving, though we could discuss that.
Yeah, they certainly, yeah, like maybe discuss it, because it's maybe in whatever local planning you're doing, incorporate ways in your local community to support caregiving, which, to Barbara's point, could include a local initiative for providing respite or some other, creative ways to do it. So I think it could actually be both, incorporate caregivers and caregiving into your planning processes. So maybe think about, that's how I might think about it. So.
And I think that dovetails with the community health workers. To me, that there's some overlap there. Perhaps those could be combined in some way, because community health workers are people who know the local community, as Barbara and others have said, so but they're not necessarily caregivers themselves or people who have had experience caregiving. So they don't necessarily know from the inside out, what this journey involves and what some of the challenges are. But perhaps there's a way to link the two of those so that we get the list shorter and we still incorporate the main ideas.
Yeah, you can see my whole approach was to do exactly that, but we'll see how far we can get on that journey, because my impression is maybe not, but we can try. Go ahead, Dr. Let me just, before I call on Dr. Maybe you didn't weigh in yet. I'll let you weigh in, and then I want to make sure everybody has a chance to speak. So go ahead, Dr. Mobley.
Thanks very much. So I'm really resonating with what I'm hearing. So first of all, let me say, this is all good. Every one of the 10 is really valuable and important. And
yeah.
I'm glad the committee came down to 10 that are really, really superb. It's always hard to choose when you've been confronted with a number of really positive things. I'm resonating with the first one, the increased options to provide care, and with the second, the local community. I think those are really valuable suggestions. So I would agree with
so can Dolores. You just, I'm sorry, when you say the first ones, I'm not sure which one you mean.
The increased options to provide care to individuals with dementia.
Okay, perfect. Okay.
And the second one is incorporate family caregiving into planning in local communities. I just think those are really very sensible, very important. The one that I really resonate a lot with, and I know it may be not everybody in the committee, but the last one, identify and pursue strategies to improve collaboration and reduce silos among departments to address the growing needs of people living with intellectual disability and dementia. And of course, that's kind of where I live. I really see an incredibly underrepresented, undercared for population. I go to clinic and I see these people, and they're telling me that they see a physician and they see other caregivers, care workers, and nobody knows about dementia and those with intellectual disabilities. It's almost as if it's a really a completely underrepresented group of people. And I believing that it's their right to have high quality care, I would certainly recommend that one. Again, they're all good. It's hard to choose three.
I could not agree. So well said. They're all good and it's hard to choose three. So let's hear from some other committee members about what they think is important. I think kind of keeping track of where people are landing, and that might help us sort of settle on something. So others who haven't had a chance to speak, is there anybody in the room that wants to weigh in?
Well, I certainly can. This is Claire. I have a question, and this may be my first and last meeting, so
I think that's highly unlikely if you're trying to escape. Once you're here, you're here.
So in tomorrow's budget discussion, some of these have a lot of feasibility if they're low touch and low cost, and others are going to be completely unrealistic depending on what happens tomorrow. Is that something we need to be concerned about or should be talking about here?
So I think there's a couple of thoughts I had about it. Someone said, maybe it was Barbara, said something about, looking for the future and really some other short-term things. So, I think we all expect the budget to not be great news, but in California's budget cycle, there's, bad years and there's good years. So I don't know that I personally think we should exclude everything that's expensive. Like some things you could do planning about and fully implement it when there was more money available. And on the other hand, I think for the communities that we all care about, trying to identify some things that could happen now is also a good idea. So I guess I wouldn't limit us too much by what one or two bad budget years might say, and I'll be willing to also dream a little bit beyond that for the future. And if I'm wrong about that, staff can certainly tell me that. What are you thinking? So anyway, did you have some ideas, Claire, about what you would recommend?
Let me rethink my brain and I'll get back to you.
Okay, sounds great. How about others? Okay, Celine, go ahead.
I know I've already spoken, but since nobody else, I would also put a strong one in, like Barbara was saying, for the community health workers, and I think it has a huge potential and impact. It can be families, and in our organization, the use of bilingual, bicultural community health workers has had a serious a positive impact on disparities and access to services when we have community health workers that represent their communities, accessing hospice, palliative care, Alzheimer's services across the board, and it's been really effective. So
thank you. Thanks for weighing in about that. Anyone else want to weigh in? And if you're not, I'm gonna reframe a question a little bit to narrow your choices given what we've heard so far, but I don't want to do that if people want to lift up something else. Okay, Barbara?
Just thinking, making me pick between respite and adult day. So I've been thinking about it, and I think I would lean towards adult day because I really do like the idea of building community. Social isolation is such a huge issue for so many of us. And certainly when people get that diagnosis of dementia, it can just pull people into their homes and just further isolate them from community. So respite is great, but if respite's happening, within your own home, it may not be giving you sort of that added benefit of adult day, which is pulling you into community and helping you maybe find a new community and support. So that's the one I'm going to go with.
Okay, thanks for that. So what I'm hearing so far is that there is a preference for increasing the benefit to access and affordability for, I'll just say, the forgotten middle, and doing something in that space. And we have several ideas. And that, as Barbara, I think, helped point out, that's a longer term strategy. I think we heard today that there's a contractor that's already working on a piece of that. And so maybe there's some reasons to continue to do some planning around that, even if the benefit, I mean, I don't think any of us expect the benefit to be available in the next 2 years anyway. And so continuing to do that work could have value, is what I heard from people about that. I also heard a lot of positive comments for continuing the work on Cal Compass. I heard Barbara encouraging a part of that to say, you know, could a piece of the person-centered adult day services, could they explore as a piece of that, offering respite as a component of that? So when we get into that one, if that's one we choose, we can see whether that fits neatly and whether that's going to cause any great problems for us if we go ahead with that recommendation. And then the last two that have kind of, I think, equal voice are incorporating family caregiving, caregivers and caregiving into local planning in communities, to increase the availability of culturally appropriate services for caregivers. And the other one is use of community health workers to provide dementia care management through aging services networks. And I guess one of my questions, Dr. Mobley, for you, because I heard your strong preference for individuals with intellectual and developmental disabilities. I'm wondering, like, because community health workers help people navigate systems, I wonder if there's a way to, you know, call out, you know, individual older adults that would use community health work, older adults and their families, but also individuals with intellectual and developmental disabilities, so they had access to, you know, the same kinds of community health workers to help with that navigation piece. So I don't think that fully addresses what you're saying, but I'm trying to give voice to the population that you care about.
No, thank you. I think, quite frankly, I think anything we can do that's positive along those lines is really a step forward. So however that might be incorporated into one of the other options, I would certainly be supportive of that.
Okay. So I think,
Yeah, Catherine, can I just add to, one of the things that I haven't heard us talk about yet is people living with dementia. And I think as the community that's looking at ADRD overall, the nothing about us without us, we should be talking about the one that popped up around ensuring that decision-making, education, and resources being developed are appropriate for those living with dementia, that they're not, caregiver is hugely important. And so I would like to.
Oh, I see that. So I think what you're saying, I appreciate that, Claire. Thank you. So it's like under the incorporate family caregiving into planning and local communities, it would be incorporate family caregivers and individuals living with Alzheimer's into planning and local communities. And we'll find a way to talk about also kind of the caregiving support. Is that what you're suggesting? Putting it there? Or did I misunderstand you?
No, and maybe it's not, did that one not make it on the top 10 and I'm looking at the wrong thing? There's one that talks about.
You're talking about supported decision-making?
Yes. Yeah, but it's just also about language, right? Making sure that the tools and materials are appropriate for people with dementia.
Yeah, it's the fourth one on the 10.
I can't, I think
Put your glasses on there.
Sorry.
So I guess the question would be, like, I mean, I think others should weigh in about the importance of that. And is there way, I guess, with the ones that people have spoken more about, is there a way to include something about it in these, like these initiatives of planning in local communities or community health workers, ensuring that the materials are, I think what you said, appropriate to, to people living with dementia as well, right? So I see like that fits nicely into like community navigators. Why would we just focus community navigators on family members, but also have the experience of the individuals and make sure that the materials are accessible and usable by them by way of example? Because I hear you focusing on that aspect, not so much on the supported decision making. So what do you think about that?
Supported decision-making as well. I mean, I think I'm wondering if that's realistic to assume that community health workers are going to be able to do all of that work. But
Yeah, I don't know. I mean, I think this is our recommendation. So I hear what you really want to do is add to the mix a new one, which is the one about supported decision making, which I'm not.
It's the fourth top 10 list, Catherine.
I know, I just have I have only the slides printed out in front of me, so I can't actually read it. So if you want to read it, that's fine, but either that or wait a minute, maybe this is appropriate supported decision-making resources for persons with dementia. Is that, yeah, which is kind of a shorter version of what the full one said, but it's dementia and their supporters, right? So anyway, it's fine to add that to the mix. I actually found that list. It's just not where I'm keeping my little tally on, but that's okay. So thank you for that, Claire.
thank you, Catherine.
Celine and then Barbara.
I really appreciate that call out. I think if we are going to go with the second one, adding the person living with a diagnosis would be important language to add to number 2, if that becomes our priority. And I think we could incorporate some other things, whether that's, communication, materials. I mean, I think we could probably capture a lot in that one.
In the incorporate family. So I think where we've landed on number 2, if we're moving that forward, is to incorporate family caregivers and caregiving. And then there was a suggestion to also add the experience of people living with dementia into local planning, right? So I think that's kind of where that one's, I think that's where that one is landing. It doesn't particularly address the supported decision-making aspect of it, which I think is what Claire was pointing out. So more to come. Barbara?
Just a process question. So am I right, when you were laying this out, were you saying that you're sort of a subgroup is going to be created to answer all of those questions that we have to answer? The first one, like, what's the problem? And then the how would we know we've accomplished it? All of that, right?
So
we're not doing all that work right now.
We can't probably do all that work. We were hopeful maybe we would get to a couple of them if we can agree on what the most important things, but we absolutely need to land on some 3, however we're going to define them, so that a small group could then do the work that would reflect this committee's priorities.
Right. So some of them lend themselves, I think, a little more clearly to how would you hold the state or all of us in the aging space accountable for them being implemented. So for example, if we went with the first one related to a long-term services benefit, that's what's happening is the state studying it, which I know they are. I know Sarah Steenhuisen is working in that. So that seems like, again, it would be easier to ensure that action is happening on it and hold people accountable. We'll have to think really strategically and maybe creatively about some of these others, about, for example, incorporating family caregiving or caregivers into planning in local communities, just to make sure that we don't just put, and I know that's absolutely, that none of us want to see this happen, where we just put things together and they just sound like these nice ideas, and then you can never really tell whether it really happened and whether actual people out there felt any of that change. So just something else to kind of keep in mind when we're trying to pick among, like, which are our favorite children, which is really hard to do.
Yes, or which children are we removing from our family?
Even worse.
Okay, others have thoughts about this? I think we haven't heard from everyone, so if you have a preference, would love to hear your ideas about what you think would be the most important.
I like the first one, which is
Yep.
options to provide care to individuals. And then the second one with the addition of ensure the support decision-making. I think, you know, we need to combine caregiver support with high quality care. But how do you kind of make that happen without like dropping off certain aspects of what we really need as a family caregiver? You know, we need a lot. We need to be seen and heard, but we also need support, and we need individuals that understand what dementia is so we can be properly guided. And that takes a lot of effort. And there's a lot of people that really don't understand dementia in the medical community, policymakers.
Mm-hmm.
So it's hard to kind of make decisions. Those are my first two right now that kind of stand out to me. And I know
So can I just want to ask a clarifying question because I want to make sure I understand. So I heard you say your first one is on the long-term services and supports benefit. Is that the first one you're talking about?
Yeah, I think that's really important because there's a lot of people out there that are having to pay out of pocket or
Yeah.
that they can't afford. There's a financial burden and insecurity among the middle class.
Yeah. Okay, so I think I actually think there's a fair amount of agreement about moving that one forward. I haven't actually heard concerns raised about that, so I think that's one that there's pretty clear consensus about. And then just I want to make sure I understood what your second one was. It was
Incorporating family caregiving into planning.
okay. Okay, got it. Okay. The other, go ahead. Yeah, please. Somebody else.
Yeah, could I just, about the long-term support services, what impact does the feasibility study that Kim referenced have on what we've outlined here? Like, what's the outcome from that feasibility study that does it have any tie-in to what we're proposing here?
Yeah, I mean, I think there's definitely, you know, I think that what the study is designed to do is to really look at what might be possible in California. So there's some overlap probably with part of this. I mean, some of the things like increasing waiver slots, you know, that's something that could be done separate, you know, has been done in the past before without, you know, the extra analysis.
Yeah.
That's a fiscal thing now. And what we'll find is, so this committee is providing recommendations. There are 5 other committees providing recommendations as well. And so what you find in this process is sometimes there's overlap, you know, where multiple committees are recommending the same or similar things. So that happens too. So that's okay.
Thank you.
Yeah.
And then I think the second one we heard a lot about was the continuing the work on the adult the adult day services programs, the Cal Compass, that are you know, have done a lot of work. And I think the worry that the work they've done will then not be able to continue, and that those services are a valuable way for caregivers to get support. And I really liked what Barbara said about that, and provide a community for not only the individual living with dementia, but also for their caregivers so that it reduces isolation from both of them. And I appreciated Barbara's comment that if you had to choose between that and respite, that respite's important, but this is a place where people can go. It provides some respite function because it's a place where people can be during a period of time for certain days of the week, but has these added advantages of supporting both the individual and their caregiver. So those are the two I hear like having the resonating with the largest number of us. And so if that makes sense to people, let's sort of say we have two of them. And then I think we have some, it's always hardest when you get to the end. The ones that people have mentioned are the community navigators. Have several people speaking of in support of that. The other one is the incorporating family caregivers, caregiving, and the experience of individuals with Alzheimer's into local planning. And the community health workers and the supported decision makers. So there's sort of three that I see rising to the top in that space. And thought maybe we could just go around and have people express their preference for one of those three, which I'm not suggesting is a easy task, but I don't really know any other way to land on something. And I would like to try and give us 20 minutes to maybe of those three begin to at least answer those first two questions for a couple of them to give our subgroup some more guidance. So I'm going to give everybody a moment to think about which of those three they want to weigh in about. And then we will just do a little round robin. And if you don't want to say anything, I'm not going to, I have no ability to force you to talk. So, but would really welcome your expertise about that.
Catherine, would you say the three again that you'd like us to
Yes. So that's an excellent question. You can all hold me accountable for saying the same three things because my papers are getting kind of messy, but incorporate family caregivers, caregiving, and the lived experience of individuals with Alzheimer's into local planning. And I think that's, anyway, I think that's one. The other one is use of community health workers to provide dementia care management. So it's kind of that community navigation function. And the last one was the supported decision-making resources for persons with dementia and their caregivers. So if you look at that list, it looks like it is the list of the 10 is number 4. Where is Michelle? Do you want to help me find the other ones?
So it's the second one about family caregiving. The fourth one, and then it was the community health worker, right? Which is number 8.
Number 8. Thank you.
I dropped those in the chat. I've just been frantically.
Yeah, so we have 2, 4, and 8. And we could also, you could also, if you don't want to say something out loud, you can choose your favorite one in the chat. So it's 2, 4, and 8. Go ahead. Someone had a question.
But so for number 2, though, are we proposing to amend language to include people living with dementia?
Yeah.
We are, yes. That's how I read it. It's not on number 2, but that's what I read out loud. Yeah, thanks for asking, Claire. Appreciate that.
Oh,
finally.
Go ahead, Myra. Please go ahead.
I've been trying to figure out how I can speak. I finally figured it out.
Oh, I'm so sorry. We should have noticed that earlier.
Oh no, don't worry. That's part of the disease. So so I was very much in favor of the family one. I think that's really, really important. and then the other one was the community work and support. I think that those are very, very important for people like me.
The community health workers you're talking about, is that the one?
Well, I kind of put them in together. You were talking about a community worker,
Yeah.
but then also a support. So the support, is that a family support or what kind of support?
So so right now we're talking about incorporating family caregivers and individuals into local planning. And then we're talking about supported decision-making and community health workers. So those are the three at this very moment. We're trying to choose among those three, but we previously did one for caregiver support. I guess we did high quality services, which is the one about adult day health services and developing that ongoing capacity and hoping that they're going to expand. So that might be the one that you're talking about there. And that one's a done deal at the moment anyway. And then also the long-term services and supports benefits.
Yes.
So I hear you talking about right now, the one that's important of those remaining is the health workers that help people navigate systems. That's what I'm hearing you say.
Yes, that's correct.
Okay. Thank you for
Thank you.
weighing in, Myra. Thanks so much.
Thank you.
So I just wanted to wonder out loud if we can, modify the language, if we're going to modify the language on one of the others, could we modify the language on this one so that we could incorporate both the caregiver and caregiving into the local planning, along with the care navigators who will also be on a local level. So maybe that could be rephrased to talk about the importance of these inputs into local levels. Can we modify the language, and could we rephrase that so that we could potentially include both of these constructs and both, both sets of ideas, because they're both important.
Yeah, so I think the question I'm going to ask about that, I'm not opposed to doing that, but I'm a big believer in incorporating as much as we possibly can. So I think the question is, so as the community health worker is currently written, we would be asking to continue funding for the is it called CalZ Connect, which is the funds that support the development of community health workers. I guess I don't know if that, I don't know how is that funding distributed locally, or is that Michelle or Barbara might know where that funding lives.
Happy to answer the question. So the CALS Connect program is the Administration for Community Living grant that the California Department of Aging received. And it's to pilot the use of community health workers to provide dementia care management in the aging network. So we've are piloting the work in 3 communities. So Marin County through their Independent Living Center, Ventura County through their Area Agency on Aging, and Imperial County also through their Area Agency on Aging. And so I think the idea for this particular potential recommendation was, that funding for those 3 sites is going to be ending. But as we've been, putting this forward and working on it at CDA, it's how do we look to expand these types of positions in the aging network, right? So like Wisconsin has dementia care navigators and all of their folks within, every county within their aging network. Like, how do we do something like that in California? So I think so it's not necessarily, it's like expanding the concept and the availability throughout the state. It may not be called CALS Connect or, this specific grant, but that's the idea behind it.
But really not about local planning, although, I mean, local people could do it if they wanted, but it's not how the funding is structured to get funding to local communities to do it, is what I'm hearing. It would go into the aging networks. I think this is the one where I was suggesting that those navigators could also help individuals with intellectual and developmental disabilities who are experiencing dementia as well, because they would be part of that population. So I think there's just hard choices to be made. So it sounds like we really just have to come to some resolution about that. Anybody else want to speak to these?
Well, if I could just make one more comment, it would seem.
Sure, please.
It would seem that we are, the second one about incorporating the caregivers could include the idea of care navigators, which might, if we added that language, which might help in the future in terms of getting that additional funding that we want for the care navigators.
Yeah, so I think it's a different initiative. I just think what you're proposing isn't really the current vision of the state about how they would use community health navigators. But I assume we could say incorporate these things into local communities, including the availability of culturally appropriate services and care navigators.
Yeah.
It's a very different model than the work that has been undertaken so far. So like, I think.
I think I understand. I was just thinking that one could help the other.
Yeah.
Down the road.
Okay. So anyway, so thank you, Dolores, and thank you, Myra. How about Sally and Barbara? I'm going to kind of force all of you to say which of these three you want to land on, or maybe you put something in chat and I didn't see it yet. So that's also possible, but I don't see that yet. People have a preference they want to voice for one of these?
The choices are pretty difficult because they're all amazing.
They are. I could not.
And even when I was getting the surveys, I had a hard time picking because they were all, how do you prioritize? I will say I agree with Barbara. I like the idea of the adult day services because I think it's so important to get these people out of their homes and to be around other people. And that's so important. So I kind of lean towards that one, but they're all truly commendable.
Okay. Thanks, Barbara. Barbara, you have your hand up. Even better.
Yeah, I mean, I really do lean toward the community health worker one because there is an initiative happening there. We're learning so much, and Michelle's reference to the Wisconsin model where there is a dementia specialist embedded within every aging and disability research center. I mean, that would just be incredible if we could move toward that model, because those folks don't only just help people navigate the system, but they're a strategic planning hub for their local communities. So, what I'm talking about here is a vision. That's what would happen automatically. It would be a process, but I see the community pushing for continuation of the work that's already been done related to community health workers would move us toward implementing that kind of a vision where every community's got leadership on dementia capability, how to strengthen it in their local communities.
Okay, so I actually think we're kind of down to two, which is the incorporate family caregivers, individuals with Alzheimer's, etc. As we've sort of refined that, maybe with the addition of, explore adding care navigators in that one, and the other one just being the continuation of the current program. And I think there are 3 people that have landed on the incorporate family caregivers into local communities. Just from looking at the chat and what people have said. And I think there are maybe 2 people so far that have spoken to community health workers. So we're going to have a little process here, like which of the ones do you want to move forward so we can kind of wrap up this part of the discussion. So
Catherine,
yeah.
keeping track here, and from the initial conversations, it looks like for the incorporation and family caregiving part, Dr. Mobley, Dolores, and Carlos had all kind of marked it out as one of their initial ones. And then for the community health workers, Barbara, Dolores, Myra, and Celine had all kind of marked that as one of their priorities.
Right,
So-
but I think but Dolores has now moved to between these supporting the local community one. As I understand it. So we've already settled on the first two, right? We've settled on long-term access and benefits, and we've and on the adult day program. And now we're down between the local planning and the community navigators. And I understand that Dolores and Dr. Mobley and one other have moved to support the local planning, and that there's, and I think Claire, because of the incorporation of the, but I might be over speaking because it's hard for me to kind of read what's happening in the room. And because of the inclusion of people with dementia in that local planning, and that there are a couple of people that would prefer to advance the current version of community health workers. So I think we just need to hear from a couple of, that's how I'm kind of thinking about the current results. So I sort of feel like there's more energy towards the local planning, like maybe 3 to 2, but it's pretty close. So does anybody else want to weigh in about those last 2 objectives? Like Celine, do you have a preference? Not to, I don't like calling people out. I feel like I don't want to be a school teacher, but
No, those are, it's tough. I just because I've seen the impact, I am leaning towards the community health workers. So that would be my vote, the community health workers continuing that work.
Okay. So now we have kind of even numbers.
Okay, so one possibility could be we could take all 4 into the work group that's going to try and build out what we have to do for each of these. And maybe in that process of maybe we could make a choice between those 2, because I'm envisioning talking about how would we make sure it's happening, how would we measure impact. That conversation, I think, Claire, you brought that up early about like how much do we think about the budget. That could be a factor between these 2 that might make us decide. And we'll have more information tomorrow and into next week about what the budget looks like. Maybe that would make us move more toward the incorporating family caregivers and caregiving.
So you're saying we already have our first 2, and because I think I feel like there's consensus about the first 2, and that they're going to move forward regardless. And you're suggesting the last 2 where the committee is, which is fine with me, the committee is kind of divided, or I mean, just feel strongly about both of them, right? It's not like we're divided and think one is a bad and one is good. They're both really good. That the smaller committee decide between those last 2, and then the rest of the committee will hear a report in August. I think that's fair, absent anybody wanting to weigh in. So we would land on increase. So where we've landed is increase the LTSS options. And the one on supporting the adult day programs. And then we would allow the small group committee to decide, make a recommendation back to us about incorporating family caregiving and including families and individuals with dementia in local planning and the community navigators, right? So everybody good with that approach? Thank you for the suggestion. Okay. We have about 10 minutes left, I think. I think one thing we should do is, if you are interested in being part of the small group, maybe say so now, but Michelle can also send out something afterwards to see if there's other people that want to participate. I think that group would benefit from sort of a diversity of experiences, right? To see that it, reflected everything the committee was thinking about. So, welcome, like you indicated, like Barbara says she would be happy to be on the work group. If there's other ones that want to do that and put their name in the chat, that's great. And also, I would just encourage Michelle to send out an email after the meeting, and then we'll decide how that group's going to go forward. I think it has to be relative, like it has to be less than half of the committee, right? Because we don't want to, we're not doing this as a Bagley Keene meeting, right? So we can have like 4 people or something.
I think 4, and if we need, like, if we have 5, then we can do it. I'll just have to notice it, those types of things, and they'll be public, but I think that's okay too.
Okay.
Carlos has also volunteered after.
Oh, terrific. That's great. Thank you.
I stared at him long enough that he nodded his head and I took that as volunteering.
Okay, different ways people I like. Michelle Johnson. Carlos has also volunteered. Thank you, Carlos. However you shook your head, apparently was persuasive. And I think either Win or I will probably join. Win had to leave. Oh, maybe she's back. Did I see? Yes, she's back. So either Win or I will join and we'll talk among ourselves to see who can be the most helpful and who has time. So I think we're settling in on that. Maybe what we'll do, just so people can get a flavor of what this will look like, just pull up that other slide that had the 2 shorter questions, Michelle. Is that possible?
Rosie, can you bring up the slide deck, please?
Okay, it's going to be, I don't know. The thing is when yeah. So where do we want to be and how will we get there? Let's just take the long-term services and supports access and affordability, and let's just talk about like where do we want to be. I think this is a easier one to do because I think where we want to be is clearer. How we're going to get there might be a bit more complicated, but so where do we want to be with a long-term services and support benefit for families and individuals living with dementia? I mean, I'll just say like the benefit itself should be adequate enough to help people pay for the cost of long-term services and supports without having to deplete all of their savings and not be able to maintain their own living arrangements, something like that. I mean, I just think that the goal is to have a sufficiently robust benefit that it will actually provide some financial relief to people. So I guess that's my vision of that.
We list options in this one too, so I don't know, we may need to define goals. Like, for example, assisted living waiver slots. Like maybe we want to say we'd like the state to consider setting aside a subset of the slots for people who are living with Alzheimer's or a form of dementia, because that's not the way it works now. So that one is a little bit of a Russian nest. That's why I love it. It's a Russian nesting doll recommendation. So I guess just like how like I agree with you, Catherine, your vision related to the LTSS benefit. I don't know if we need to also,
I think we should talk about all 3 of them. I think there's different,
okay.
What is the vision for all 3 of them? So I was just choosing off a piece I care about, but I think that we should speak to all of them. And really the first 2 might connect better because you could either provide a state funded benefit or you could establish like tax-free savings accounts that achieve the same purpose. And both of those first 2 really are designed to allow people to have the funds to pay up at least a portion of the care of the long-term services and benefits. And increasing the waiver slots in some ways does the same thing for a group of people, because then they would have access to a waiver slot that they would be in a better position to access. So I think those have similar, but maybe some more targeted kind of specific things that could be said. So
I have a question
please go ahead.
regarding the long-term services and support benefit. Because this comes up a lot in support groups. What about the people who have early onset, who don't qualify for Medicaid and Medicare because they're under 65? How would this kind of help out with people that need like long-term care services?
So I like what you're saying, Carlos, because it's not, it requires this group to think about like what, like the vision is who's going to be covered by it, right? Which should include like, does it include people with early onset and how would that work? Right. And to be clear about that. So I think that was
it would, because it would be it would function, at least the way people have been talking about it, it would function like it would come out of, like we contribute to Medicare through our paychecks, right? So we would be contributing to this. So once you have vested, you would have access to the benefit. And that would be all kinds of people across California who would need support. So it wouldn't be tied to a particular diagnosis or your age necessarily. But if you're a working individual, so we really are probably talking, we're talking 18 plus. But I think it is designed to be available to the
I
larger
think
community.
Carlos's only point was to be explicit, I think, about that. So when people read it, they have clarity that this is a benefit that would be available to all Californians, either through a payroll system, or it could be like, some people might, like, I'll say myself, like I work some, but I don't work all the time. And maybe I would like access to a voluntary benefit that I could contribute to put money away on a tax-free basis that would pay for it. So I think just broadly describing who's eligible for this would help people understand something about our recommendation in addition to the other kind of what's the goal we're trying to achieve, which is to really just make long-term services affordable for people. And there might be a different eligibility requirement for, as we know, the assisted living waiver, right? So thank you for that, Carlos. And thanks, Barbara, for like all years. You're so smart about all of this. So it's really helpful. Okay, and in maybe the last 5 minutes, why don't we just take a minute or two to say something about this one and how will we get there? Like, what is it we need to do? So for each of these, how will we get there? I liked Barbara's example, which might fit under the how will we get there for assisted living waiver. She's like, rather than say to the state, you're going to expand the waiver in a bad budget climate, which they might be disinclined to do, that instead you're going to say 10% or 20% of the assisted waiver slots that currently exist are going to be set aside for a targeted population, which could be individuals with dementia or individuals with intellectual and developmental disabilities and dementia, for example, as a way to be inclusive, to Dr. Mobley's point about kind of the broadness of the populations that can be served. So that's an example to me of a creative way to say how we might get there. Other ideas for the other ones about how we're going to get there?
This is Celine. I think before we had also talked about, from a policy perspective, people with Alzheimer's disease and related dementia being called out as a specialty population in CalAIM, which, doesn't really cost anything. I mean, we're an enhanced case management provider, and so we can serve that population, but just putting them out there as a specialty population that the health plans might be dealing with.
And
I love that idea, Celine. That's beautiful.
Does that fit within this long-term, this one that we're talking about right now, Celine, you think?
Well, I was just thinking of LTSS in general, so probably not as a benefit, but I mean, as we're talking about the benefits we have in California and places, I mean, I know this is targeted towards people that are non-Medi-Cal.
Yeah. I mean, it's a great idea. So like, I'm not disagreeing with you. I just like trying to
Yeah.
focus on what we're doing. So we might have, I don't know, that seems like a nice recommendation for the secretary for us to make in what we're saying to him later today as a reminder, calling that out specifically, which I think would be helpful for people who are Medi-Cal eligible to be able to receive specialty care. So it's actually a really good reminder.
I
Okay.
second that of putting it into the letter. Maybe it doesn't fit quite here, but putting it into the letter, the
Yeah, I
secretary.
just think it's a really great,
Yeah,
it's a really
good
great
idea.
reminder. Okay, Michelle, we're at the time we're supposed to take a break, right?
Certainly are.
Okay, how handy. You guys did some amazing work. That was like, it's really hard to make those kinds of choices. And thank you for all the really terrific ideas about how we can do that and try and incorporate as many good ideas as we have. Thanks to Barbara for the process suggestion, so we just didn't end up in a completely stuck place. And Michelle for all the clarity you provided and guidance as we were developing it. We're going to take a lunch break for 30 minutes. And then we're going to come back and talk about our legislative agenda. And Wynn is back with us. And so she is going to lead us through that discussion, which is going to be great. We have some great speakers. So we will come back at 12:50. Thank you, everyone. See you then.
Hi, Rosie. In case you didn't hear, can you go to the next slide?
Go. I believe that Wynn's gonna start this part of the meeting.
That's right. It's fabulous. Thank you, Wynn.
The only problem is Sally, I'm not, or I'm sorry, Catherine, I'm not, oh, there she is, okay. I'm gonna win. We are ready for you.
We can't hear you though, because you're on mute.
Can you hear me now?
Sure can.
Thank you. I'm so sorry for missing most of the action this morning. I am back.
We are so happy.
All right. Well, we are moving on to our legislative update, and we actually have a special guest today who happens to be a past member of this committee. Dr. Is it Sigal Gidan?
That's correct. That's correct.
Yeah, so I've known her in the last year working on the Dementia Care Aware. So I so appreciate you being here with us. And then it will be followed by Jason and Barbara, whom you all know. So take it away.
Okay, well, thank you for giving me this opportunity to speak with you this afternoon. And I just want to acknowledge that I know this is climate in the budget is not the most opportune for what I'm going to be talking about. And for some of you who've been on the committee, some of this is going to be a little bit of deja vu. My colleague from the California Alzheimer's Disease Center at UC Davis in the East Bay made a presentation 2 years ago. But I'm here to sort of do a reprise. So I am a director of one of the 10 California Alzheimer's Disease Centers. And so a little bit of history for those of you who know who we are, to update you, and those of you who may not be familiar. So California had a investment about 40 years ago in seeing the increasing aging population and the potential that was going to have an increase in the number of patients with cognitive impairments and families dealing with these issues that you've all talked about this morning. And so in 1984, the legislature established through very foresight centers to be established at medical schools. And a year later, in 1985, there were 3 Alzheimer's disease diagnostic and treatment centers. That was the name originally. Described what the centers were supposed to be doing, were established. And I direct one affiliated with USC located in LA County at Rancho Los Amigos, which is part of the LA County Department of Health Services, the safety net system. And we were one of the first 3. So we've been in existence at this center for almost 40 years. And that has grown to 10 Alzheimer's disease diagnostic and treatment centers over the next decade into the late 80s and early 90s. And then in about 1999 or 2000, the centers were renamed, called the Alzheimer's Research Centers of California, or the ARCs, because the work of the centers was expanded to engage in cooperative research projects across the multiple centers. As an infrastructure had been developed in the ADTCs, it was felt that this was an opportunity to do some really interesting collaborative research. And there was some enhanced funding that came with that at that time to support these activities. And it was a very fruitful time for a short window. And then in 2008, state found itself in a fiscal crisis. And we were defunded about 50%. And we were and it was determined that the state should not be doing research. And so research activities were removed, and because they were removed, funding was removed from the centers. And we were renamed at that point the California Alzheimer's Disease Centers, and the funding was reduced, as I said, and then we became part of, during this time, the Department of Public Health in the Chronic Disease Division, where we have remained since that time. So next slide. Can someone move the slides? Oh, yeah. So there is this statewide network. They are located, again, at medical schools throughout the state. And this gives you an idea of where we are. There certainly are lots of areas in the state that we don't reach, but most of us have been working on outreach of our centers into various areas. So there's two associated with UC Davis, one in Oakland and one in Sacramento, two associated with UC San Francisco, one in the city of San Francisco and one in the Central Valley in Fresno. Stanford University in Palo Alto has a center. UCLA has a center here in Los Angeles. University of Southern California has two, one in Los Angeles and one at Rancho Los Amigos. UC Irvine in Orange County has a center, and UC San Diego has a center. Next slide. So the legislative mandates for the centers when we were established in 1984 were twofold. Improving diagnosis and treatment for persons with Alzheimer's disease and related disorders, and providing education and training. And education training is both professional and consumer. That was felt to be very necessary, that we could enhance the care for older adults by training students, residents, fellows, and practicing clinicians, and we continue to do that. That's why the centers are located at medical schools. And we, not just medical students, but we train social work students, pharmacy students, nurses, nurse practitioners, PAs, the whole range, neuropsychologists as well. And we also have a big piece for consumers, for patients, as well as family and care partners. And so this intersects a lot with the things you were talking about this morning, about needing to support better care and services for our patients and families beyond diagnosis and treatment. And we're very actively engaged in that, as well as in the active improving of care for individuals with dementing diagnoses through our actual practices and our trainees with students and with clinicians. Next slide. In 2008, funding was slashed. We had been funded initially at $320,000 a center in 2000, and that was increased to $585,000 when we were expanded to do research, to support the research. And then in 2008, we were slashed to $282,000 per center, an almost 50% reduction. And this funding has been stagnant for 15 years. Now, we all who live in California know that what you purchased in 2008 with your dollar, you can't purchase with that same dollar in 2024. So the equivalent of $282,000 per center in 2008 dollars would be $392,000 this year, significantly more. And if we had been maintained in our funding at $585,000, that would be about $830,000 per center. And so I'm here basically to plead that we can't continue with stagnant funding. Over the last 15 years, the funding has not changed, and there's inflation, and there's increased healthcare costs, and there's increased costs of doing business. And it's just not possible. We still have the same mandate to provide care. Each center is required to see at least 100 new patient evaluations. Many of the centers see more than that We provide training and outreach to our communities, increasingly trying to reach people through the web, and not just in person, but with other outreach activities. But all of this requires money, and you can't do it with the same amount of money for 15 years. And so something has to give here. And the reality is that the current funding is insufficient to sustain these centers. Somebody this morning talked about having national leading models of care, and California established these, again, I said in the mid 1980s. They became the model for what the federal government has done with the National Institutes on Aging centers, and the model for what has happened in other states. And we are falling behind the times. Next slide. So the center I run is just one center. It is the only center located at a publicly funded hospital. All the other centers are located at University of California centers, except for the Stanford Center, which is located at the VA. And so I'm in a little more precarious position than many of the other centers here, because I have no other funding. I don't have a National Institute of Aging funding, and I don't have a university to supplement things. And so what's gone on in my center, I don't think is too different from other centers, but it's becoming critical. So I've given you here a snapshot of the staffing changes since 2008, where we have had to reduce the percentage of effort people are being able to be paid for through the center to conduct the activities. And we've had to eliminate a number of positions, including a community outreach worker and a neuropsychologist. So we have reduced the amount of access to services for the patients and the populations we serve. And we have been supplementing and making up the difference with research grants and other funding that is drying up. And the reality is, for my center, and is more critical than other centers, but for almost all the centers, without some additional funding, I don't think the centers are sustainable. Even though they are legislatively mandated, the current funding is just not fiscally sustainable to do what the state is asking us to do. So next slide. So I'm here to request, actually to beg, that you use your influence, which I know is too late for this year's budget. But there are changes that can still happen to the budget. And then there is next year's budget, which might look a little rosier. But I know that you make recommendations to Secretary Ghali that go then up to Governor Newsom. And I know that he has a commitment to Alzheimer's disease, as we heard at the beginning of the meeting today from the state plan. But I think somebody needs to make it clear that the current funding is insufficient to meet the legislative mandate. The state has invested almost 4 decades in the CADCs. And that is millions and millions of dollars that are now not going to go anywhere for the growing population of need. And so my request is for a budget of $2.2 million, in addition $220,000 per center, to raise each center's funding to about $500,000 a year, which is what it would take to do the minimum that we're being asked to do. And then to think about beyond this crisis, because I've been here before. I've been here twice before where funding was stagnant, and we had to go begging the legislature for more funding. And there needs to be a regular reassessment of funding to align with the legislative mandate. Otherwise, someone after me is going to be here in 5 years, 8 years, if we are able to sustain the centers, asking for this again. So that's my request, that you seriously think about a recommendation to Secretary Ghali of the need to support these centers if we're going to continue to create a national leading model for care that can support the other work that's going on through the state aging plan and the state Alzheimer's task force plan. So thank you for this opportunity. I'm happy to answer questions. And you can certainly contact me by email if you have other things you want to talk about. But thank you.
Thank you so much, Dr. Sigal-Gidan. Yeah, this is definitely something we should all be thinking about. One of our recommendations from the task force is to keep California at the forefront of cutting edge global research. And this is one of our venues. Do we have time for a question now or afterwards, Michelle?
Sure. after Barbara has finished, we should have 10 minutes for questions.
Okay. All right. So do we have Barbara or?
Jason is next, and then Barbara. Rosie, can you put the slides back up, please? Next slide. There we go.
Okay, and then you can go to the next one already.
Next slide.
Okay, I'm going to go over the 4 bills at the Alzheimer's Association that we're sponsoring this year. So the first is AB 2680. Concerning this advisory committee, we're trying to expand the membership. I spoke on this last meeting, and I think the bill was also introduced last year, so it's nothing new. Trying to include up to 25 members. Right now it's at 14, so we're going to try to increase it with first responders, primary care physicians, public health officials, and then even one of the commissioners on the Commission on Aging. And then we're going to revise the phrase Alzheimer's disease to Alzheimer's condition or related disorders. And then also we're going to remove the 1-year term limit for the 2 committee members that are living with Alzheimer's or related dementias. We don't think that's fair. So they will have the same term limit as everyone else. And so that bill has been sailing through on consent. It got through consent on Assembly Health, and now it's in Assembly Appropriations and is recommended for consent as well. So hopefully we don't have any issues with that, but we will see. And next slide, please. This one's also sailing through. It's a non-controversial bill, but it's AB 2689. It's the Alzheimer's Disease and Related Dementia Research Voluntary Tax Contribution Fund. So many people just got done filing your taxes. If you did TurboTax or if you did your taxes, you'll see if you got a refund from the state, there's options that you could donate to specific causes. And Alzheimer's is one of those, and it was going to expire in 2025. So we're introducing this bill to extend this contribution or this voluntary tax contribution fund till 2032. And just a little background on it, it has been very successful for the previous 6 years. It's raised more than $500,000 annually to provide research dollars to specifically California scientists. And then a recent grant awardees include UCLA, UCSF, USC, for their work on reducing disparities in diagnosis in California's diverse population. Next slide, please. And then just an FYI that Assembly Member Soria is going to introduce our annual resolution recognizing June as the Alzheimer's Disease and Brain Awareness Month. So be on the lookout for that. And then before we move on to Barbara, I didn't have a slide because we didn't know exactly what was going to go on with our bill SB 639. We introduced that last year during the Dementia Care Aware program. It's over in the Senate. It's a 2-year bill, but we're actually going to turn that into a physician training bill. And so currently physicians that if they have over 25% of their patient population is over 75, they have to complete 20% of their continuing education in what's called the field of geriatric medicine or the care of older patients. And what our bill is going to do is add specifically special care needs of patients with dementia within that requirement. And then also we're going to add this, which will be a new requirement for nurse practitioners and physician assistants, because we realize that a lot of times they are seeing the patients and early diagnosis is very key. So we figured that physicians need to up their training that they currently have, and we figured that nurse practitioners and physician assistants should be trained in this as well. So like I said, it's not in print yet. It should be in print probably next week. Our advocates advocated on this bill Tuesday during our advocacy day. Got a lot of great response to that. So hopefully it'll pass. That's it for me.
Great. Thank you, Jason. All right, you can go to the next slide. I'm going to start with talking about legislation that my organization, Alzheimer's Los Angeles, along with Alzheimer's Orange County and Alzheimer's San Diego, has put forward. And then I'm going to branch out and I'm going to talk about a range of bills that impact our families in a variety of different ways. So this one, just to refresh everyone's memory, this is an effort to try to address the issue of wandering. And it is focused on the Commission on Peace Officer Standards and Training, directing them to develop guidelines to improve law enforcement response The bill outlines specific topics that we want post to address when they're developing those guidelines. Next slide, please. These are some of the other topics that we want to ensure are addressed. Again, this is all predicated on work we did here in Los Angeles County when we created the LA Found program. So we want all of those, all the years of work and learning that we did here in Los Angeles County to inform what happens on the state level. Can you go to the next slide, please? So where our bill is, we actually have already made it out of the Assembly. We're in the Senate, and this is what I get for like putting it on the slide, because I knew this was going to have changed by the time I'm presenting to you today. We have actually been assigned to the Senate Public Safety Committee. So not yet set for a hearing date, but we moved through the Assembly pretty smoothly and are hoping for the same in the Senate, and certainly hope that the governor also chooses to sign the legislation so that we can get started. But I did want to do a callback here to Kim McCoy-Wade's comments about a work that she sees potentially on the horizon in this space, and she mentioned wandering. And so I just want to underscore that this bill, if it were to pass, does not fully address the issue. It's a key piece of it because it is focused on law enforcement. There's so much else that could be done at the state level to provide counties with guidance on how to better support families, help them prevent wandering, help them respond when it does happen. So this bill is a really important step forward, but we definitely hope that there is even more engagement from the governor's office and relevant agencies to address the issue more fully as we move forward. Next slide. This is an interesting piece of legislation. There is already a Blue Envelope program in Riverside County and in San Diego County, and there may be one other county. This would have created a Blue Envelope program that would have been statewide because it would have been administered by the Department of Motor Vehicles. And actually, just like our Wandering initiative, it is bringing together the autism community and the older adult dementia community, because for different reasons, wandering is an issue and communication with law enforcement is an issue. And there have been some really tragic stories out of both of those communities, unfortunately. So this bill, though, is currently being held in the Assembly Appropriations Suspense File. I'm going to be saying that about a lot of these bills because, as we all know, the budget situation is not great. So any bill that comes with any cost at all, not any cost at all, but over a certain amount is just sort of automatically being held in appropriations. And so this is just caught up in that as well for this session. Next slide. Okay, so I'm going to move on now to what I think of as sort of caregiver related legislation. There are a number of bills. At AB 518 is the first one that I'm going to talk about that are related to basically making the paid family leave program work better, make it easier for people to access. So right now, you can access the unpaid family leave program if you are certain relationships with individuals, or if you are a designated support person, so chosen family. Those folks can still benefit from the job protection that the unpaid family leave program affords. But when it comes to paid family leave, you can't be one of these family members, family of choice, designated support person, and access the paid family leave program. So if this bill were to pass, it would allow for the unpaid and the paid family leave programs to be sort of giving people the same range of opportunities for people in their life that could provide them with support. This bill was held in the Senate. It made it out of the Assembly, held in the Senate. So we're just waiting for it to move again on the Senate side. The next bill, AB 2075. So this is a bill that our California Department of Aging was involved with, relates to legislation from last time. So they had a working group, maybe a stakeholder group, I'm not exactly sure the term there, to take a look at how we could ensure access to residents in long-term care facilities. You all remember what happened during the pandemic, and it was really tragic, especially for people in those facilities living with dementia. We saw really significant declines much more quickly because they did not have access to that stimulation, socialization that they were getting from visitors. So This bill started out as a designated support person access, and it's been amended since so that it's just ensuring visitor access to people who are living in these facilities. It did pass out of Assembly Aging and Long-Term Care and the Assembly Health Committee, and it has been re-referred to appropriations. Last I looked, it has not yet been set for a hearing, but it also doesn't show as being held in the suspense file. So I'm still optimistic because this is really important legislation that we need to see pass. Next slide. Continuing on the subject of access in healthcare settings. So AB 2549, original version of the bill, wanted to guarantee family caregiver access across a whole range of healthcare settings. It was subsequently narrowed to just ensuring hospital visitation. This issue has come out of our support groups where families have talked about, you know, their loved one with dementia going into the facility and that particular hospital's visitation requirements, making it very hard for them to have access to their loved one in a way that they felt was important for their safety and honestly for quality of their care. So we think this is a nice companion bill to the previous one that I just mentioned. This one, however, has been held in appropriations. And so its continued passage is a little uncertain. Next bill, I'm going to go back to SB 1090. I'm circling back now to the paid family leave program. So this is one of those where when I first saw the bill, I was like, you can't already do this? This is like a head smacker bill. So the way the paid family leave program works now, you actually have to already be out on leave before you can apply for it. And then it backdates to when you first had to go out on leave. But what this bill would do is allow people to apply for it when they know they're going to be going out on leave. Maybe a family member is having a surgery and they know they're going to need to be providing care for them. Or if you're having a baby, you know approximately at least when you're going to have that baby. And so this would allow you to apply for those benefits in advance of actually going out on leave, which just, again, makes so much sense. And also, unfortunately, this bill is sitting in the Senate Appropriations suspense file. The next one, AB 3079. Some of you may be aware that last session, the Medi-Cal program was opened up to people who are, regardless of immigration status, so that you can access Medi-Cal benefits, which is fantastic. And so this would include the in-home supportive services program, which we all know is so important for keeping people safely in their communities. But right now, there's such a challenge in finding people to serve as in-home supportive services workers. So if you don't already have a friend or family member that you know is ready to go to be your IHSS provider, even though you've been approved for the benefit and maybe approved for hours, you might not actually be able to get the care because you can't find someone to do this for you. So what this bill would do is kind of line up who's able to be a provider with who has access to the program now. So if you're a family member of someone who's undocumented and you yourself are also undocumented, you would actually be able to serve as your loved one's IHSS provider. So this bill did pass out of the Assembly Human Services Committee and has been referred to appropriations. I don't believe it has been set for a hearing yet. But I also don't show it as being in the suspense file. Okay, last bill on this slide, going back again to our paid family leave program, AB 2123. This would allow workers to be able to access paid family leave without having to use all of their vacation time first. Again, just seems like a bill that's just supportive of the realities of our caregivers and the fact that, you know, they need to be able to maintain some of their vacation leave so that it gives them greater flexibility for meeting the needs, their own needs or the needs of their family members. So this one did pass out of the Assembly on the 25th and has been referred to the Senate Labor, Public Employee and Retirement Committee. So it is still moving. Next slide. Okay, now a couple of bills that are related to home and community-based services. We've talked some already today about the CBAS program. This is adult daycare. AB 2428 This is a little bit in the weeds. I'll just say that it's looking to set a floor for reimbursement rate to ensure that whether the individual receiving the service is in a fee-for-service insurance health plan or in a managed health plan, that center is being reimbursed at the same rate for providing them that care in the CBAS setting. So this bill is probably not going to be a surprise to you all. It did pass out of Assembly Health Committee, but it is currently in Assembly Appropriations suspense file because it does have a dollar amount associated with it. I'm going to keep going because we've got a lot to cover here. So the next bill, Senate Bill 875, this is, so if you have ever worked with a family or families who are families who are looking for placement for their loved one in a facility, oftentimes these referral agencies, and there are a variety of them, some of them are big on the internet, have a big presence, can help families find facilities. They are currently unlicensed, and there are some issues with some of the experiences that families have had. This bill has been, I think this might be the third year. It's been around for a number of years now. It's controversial, but some of what would be in this bill, for example, would be ensuring that if you don't place your loved one in facility A, you place in facility B, that if you tell facility A to not continue contacting you anymore, that they're not allowed to do that. This is one of the points of contention where there are folks who say it should not be you shouldn't have to proactively tell that facility A not to contact you anymore. Facility A should just now no longer be able to contact you because you have already decided on placement in facility B. So lots of negotiation I know that has happened around this bill. It did pass out of the Senate, and it is awaiting committee referral in the Assembly. Next. Okay, this is a bunch of legislation related to facilities, and I wanted to share all of this with you guys because we know that a really significant percentage of the residents who are living in these different care settings are people living with a cognitive impairment or dementia of some kind. And we also know that those folks are some of the most vulnerable living in these settings. And so I think all of these bills are really important toward ensuring that they're getting quality care and that they're being protected appropriately. So the first one, AB 1911, this is related to how complaints are handled in these residential care facilities for the elderly. So ensuring that if a situation really involves danger, that there's some expedited process for handling that complaint, provides more guidance on how, if you're the person who has filed the complaint, how the agency needs to be communicating with you about what's going on, a process about if you don't agree with the decision that has been that they've come to, how you can challenge that decision. And so again, we see this as important for, again, ensuring quality care for the resident, as well as giving the caregiver, the family members, a little bit more of a sense of how this process works and how they can advocate most effectively for their loved one. AB 1993, this one is related to, again, these residential care facilities for the elderly, which are currently capped at 6. 6 is the maximum number of residents that they can have. And this one would change that so that it could be 10 or fewer residents that would be in these facilities. So some of the issues related to this bill are about, we have a housing shortage. It can be very difficult to find a quality placement. So potentially, if these facilities were allowed to have more residents, it would make this option more accessible to families. So this bill is also in the Assembly suspense file. The last one on this slide, SB 1040, I'm sorry, I just skipped one. AB 2356, this is related to increasing the monthly amounts for people in nursing facilities to cover personal expenses, $30 to $50. I mean, that just might seem like such a small amount of money, but for these folks who are in these facilities, it really can make a difference for them. And so this bill is also in the Assembly Appropriations suspense file.
Barbara,
okay,
we're at
yes.
123, so if you can speed it up, that'd be great.
Okay, let's just go to the next slide then. You know what, let's just go to the next slide because bills that aren't going anywhere. Okay, so let me talk about this one. You might be thinking like, why is there a firearms legislation bill in her legislative update? This is also an issue that has organically risen from our families. You know, you've got someone who might be former military, former law enforcement. They have always had access to weapons throughout the course of their life, and then they get dementia, and all of a sudden the situation gets challenging for family caregivers. So this bill is not specific at all to people with a cognitive impairment. This is just a requirement for anyone who owns a gun that it be stored safely. But we did weigh in on this bill in support of it because we do see this as being very helpful to our family caregivers. Sometimes when you can say to people, it's just like when you need to take a driver's license and you've got the doctor there saying, this is what needs to happen. If you can point to, you know what, this is what the law says we need to do. We need to store it in this way right now. It can just be another tool to help family caregivers do what they need to keep their loved ones safe. So this one is out of the Senate. I'm looking on my list now, and has been referred to Assembly Public Safety. Okay, next two, I'll go quick. If I can go next slide. This is another version of a bill so the previous one was another version of a bill to try to increase funding for community-based adult services, paying through a different avenue though. Its path is uncertain. And then the final slide, which is going to talk about funding for the long-term care ombudsman program, such an important program, as I mentioned earlier, about the percentage of our folks who are living in facilities. And this program is such a key advocate to ensure safety. And just like Freddie was talking about in the beginning, you know, we're in another situation where funding and staffing are just not anywhere near what they need to be to ensure safety. So I'll stop there.
Great, thank you so much. Now it's time for question. I think we have until 1:30. I think Dr. Mobley had a question earlier. Did you want to?
Yeah, thank you. So I'm just, of course, very supportive of the ADCs. Really think that they're critical. Give me a sense, if you will, for how one can argue in favor of the increase that you're asking for. In other words, a look at the budget to really show we need X% effort for this kind of person and that kind of person. Have you worked that out, Dr. Gadan?
Well, I think the reality is that, you know, if you look at $280,000, you can, I mean, and you look at what salaries are today, it just can't pay for people's salaries to support the running of a center. I mean, small amounts of physician time, neuropsychologist time, but even just to have a receptionist, you know, to have a receptionist who answers a phone that's dedicated to a program is, you know, 50,000, 55, 60,000. I mean, the UC set certain, you know, plus benefits. So if you have, you know, a receptionist who's going to answer your phones and not have a voicemail message there that people can talk to, you figure it's 80,000, and you know, what can you do? You're just, it's minuscule. The funding cannot support the centers to operate as centers. You know.
Yeah, no, I get you completely, but I'm just wondering, so you've worked the budget out so that the amount that you want to get per year, which
it's about $500,000 per center.
Yeah, $500,000, yeah. The amount you want to get per year properly covers the effort for all those people that you feel are
the minimal effort to actually support a center. I mean, I guess someone could come up with a rubric, you know, you to have a center that sees 100 new patients and follows some of them over time, and provides training would require X%. I mean, we could work that out. It will be different in different parts of the state, and different depending on where the center's embedded.
Yeah, I'm just thinking in making your case, I'm wondering if you can make the case that the care that you provide really adds extraordinary value to the care they otherwise would get from their primary care providers, so that, you know, what you're doing is not just caring for these people, but you're making it easier for their PCPs to do so.
Well, I think that's part of it. The other is is the training part. I think actually it's the training of the future healthcare providers, the students and the residents. There's a growing body of literature that says that if you don't expose somebody to a topic when they're in training, then they're not going to carry it forth into practice.
Yeah, I'm sure that's true. Yeah,
And I think that's the piece that we really have. It's the investment in training, and it's a small amount of investment in the time for a center for the potential benefit to the greater good from the trainings. I mean, what we hear repeatedly from primary care providers is that I don't do this because I wasn't trained to do it. So that's my argument, really.
Understood. I think the arguments are really good. I hope that they're heard.
Me too.
Right. Thank you. Catherine?
Thank you. I know we're short on time. I wanted to just ask a couple questions about the bill that affects our committee, because I have been passionate about that over the last several years. And honestly, I'm a bit worried about what happens on the other house. So I guess 2 questions. Have you asked for any technical assistance from the administration about any changes that might need to be made from their perspective? And second, has there been any cost? I understand it's on consent, which is good news to move out of appropriation in its first house, but has there been any cost assessment yet that might get it hung up at some future date?
Not yet. Like you said, it's probably gonna happen in the Senate approves. The same bill last year, I think the price tag was 150,000 because they were thinking of added members would have the cost to get people here, but we are thinking of putting in their language that say specifically, because it's an advisory committee, that it could be held virtually. And so, I mean, if you see this meeting here, I think 2 members are actually here. And so you're saving on airfare, hotel costs, meal costs. So that's what we're gonna make sure we talk to them when it gets to a Senate approves, is that not all 25, if there was 25 or even if it was up to 21, are gonna be here 4 times a year into Sacramento. So the cost should not be even 150,000. And then we did think if they really did stick with that, we were probably gonna decrease it by a few. We don't know which ones yet, but maybe just keep it to the ones where the secretary can identify 4 people that they could put on. But yeah, the costs will come up in the next house, but we're prepared to say, last year you didn't take into consideration that a lot of people attended virtually.
Well, and the Bagley
Yeah,
changed last
changed,
year
yeah.
after the bill had
Right.
died.
Okay, thank you. I guess there are parts of that bill that are very important in reducing the stigmatizing language about how we refer to people with Alzheimer's and, standardizing the terms. And those don't have any costs whatsoever. And I at least will hope that if the costs get hung up with the addition of other members, that you would consider reducing the bill to at least the things that don't have costs, so that we could see some change that really is important.
Definitely.
I'm sorry, I didn't hear what you said.
No,
So sorry.
definitely, yeah, that you don't want that to always get caught up and not moving forward because of cost.
Right, so we had that experience before, so I'm trying to put a plug in gently about, like, there is a way to have a victory in this bill, even in a bad budget climate, by, if necessary, reducing the cost to nothing, because I don't think those other 2 items, they're statutory language changes that are gonna impact, that have any cost impact. So I'll leave it with that, but thank you. And thanks for your work on it.
All right. Thank you all. Michelle, are we up for public comment? I guess Carol.
Yes. Rosie, can you put up the public comment slide, please?
This is our public comment period. As we wait for the slide for instructions, here we go. One more, I think, Rosie. Great. This is our public comment section of the meeting. So if you would like to provide comments to the committee, now is your opportunity. In the room, you will raise your hand and Michelle will get her attention. If you're on Zoom, you may use the raised hand icon. And if you're calling in by phone, press *9. So let's start. And of course, any written comments can be provided at any time to our Engage email box at engage, ENGAGE, @aging.ca.gov. And just a reminder, public commenters will have 2 minutes so that we ensure everybody having an opportunity to provide comments. So let's start with the room. Michelle, any public comments there?
There are none, Carol, thank you.
Okay. And any attendees via Zoom? If you'd like to provide a comment, please hit the raised hand icon on your Zoom tool functions. And I am not seeing any public attendees wanting to provide any comments. Please remember, you can provide your comments at any time via email, written to engage, ENGAGE @aging.ca.gov. Let me do that one more time. Engage, ENGAGE @aging.ca.gov. And we'll make sure to get those to the committee members. Whenever you'd like to move on, Michelle?
And there was no one by phone, right? That we
No
know
one
of?
by phone? No.
Okay, great. Thank you.
Next slide, please, Rosie.
Okay, thank you.
Catherine, I believe this is you.
Okay, so I think we talked throughout this meeting about some recommendations that we wanted to make to the secretary. And so let's ask people in the Zoom room if there are specific things that they want to mention, and then we'll take comments from other people that are participating by Zoom. So meeting room Zoom people, do you have anything you specifically want us to raise with the secretary?
There is not.
I'm having trouble hearing. You said no, there's nobody.
Not at this time, Catherine. Thank you.
Okay, great. Are there other members of the committee that want to identify items? For those, actually, I should just step back for a second and say, for those of you that have just joined the committee at this meeting or the one before, at the end of each meeting, we have the opportunity to provide input to Secretary Galley, who is the person that is responsible for this committee, but also the entire Health and Human Services Agency. So this is our opportunity to raise specific points that we are interested in. So that's the context for this. People, go ahead, Dr. Mobley. Thank you.
Yeah, I think that he ought to know how proud the committee is of its work and how much important work's being done. And its leadership, who's done a really excellent job of organizing our meetings and allowing for really thoughtful discussion. So one is, the committee is really pleased to be part of the committee and to see how all the good work it's doing. A second would be to really push very hard for the understanding that the work is being done and the need for ongoing work in this space is really critical, and that whatever process is involved in deciding in the budget what gets funded and what does not, that this work of the committee is extremely important and it has to be sustained because it's just critical for the well-being of California. And then a third is I would definitely I would definitely support the continuation of, and in fact, the increased funding for the ADCs, as was discussed just very recently now.
Okay, thank you for that. And Barbara, you had your hand up.
So I'm wondering if we could include the last item that was in the master plan discussion, the one related to silos with the DD. That just seems like something the secretary could just make happen. Like, I don't know that we need to, so I think maybe we could include that in the letter to him, as we'd like to see you take leadership and ensure that, these silos are broken down and, so I'd like to just take that potential master plan on aging item and reword it so it fits into the letter to the secretary.
Yeah, that sounds great. Thank you for that. Thank you for that suggestion. That's great. So we have, I think, 3 or 4 things so far. Other people want to add anything else? Okay, while you're thinking, I think Dr. Mobley, I think you alluded to this, and I might, or maybe it's different, but I think I would frame something about, we look forward to working with the secretary to advance aging priorities, even in this difficult budget time, because we know, the population that we serve is expanding and the needs are great. And something along those lines of just being willing to be a group that can help figure out priorities that can move in a different budget climate. So I think that's what Dr. Mobley in part was saying. So maybe we just sort of focus on that. And Wynn wants to support Barbara's comment. I agree that that's a really good one about moving the silo to this area. And then I want to encourage the secretary to provide or obviously staff, but technical assistance if it is needed around the bill about our committee, because I think this is really a nice opportunity to advance the membership of our committee, if that's possible, but also ensure that individuals who fill what we call consumer slots have the equality of the same term, and that we kind of eliminate the outdated language that is how we describe them. So just want to encourage that there's sort of a proactive reach out to the sponsors of the bill to help avoid last minute surprises with what might happen. The other thing that we talked a little bit about, there was that supported decision-making discussion, I think, that Claire was raising. The State Council on Developmental Disabilities received, I think, $5 million to develop supported decision-making materials that were designed both for people with intellectual disabilities and people with aging. And I think it would be great if the secretary or his staff could follow up with the State Council to understand how older adults are being how the materials are being adapted for older adults to use, given, somewhat different circumstances than individuals with intellectual and developmental disabilities. So maybe there's a way we can include that, picking up on Barbara's good thought about things that we're not advancing, maybe through the master plan priorities can find another home. And it kind of makes sense to work with the same agency that's doing supported decision-making to adapt those materials so they're useful in another community. That's what I have. Other people, I think we did a lot of work today. You should all feel quite proud of what we achieved. It's pretty remarkable to go through that priority setting process and have some brain power left to think about other things at the end of the day.
And Catherine, I also captured the earlier one about calling out people with dementia as a specialty population.
Oh, thank you, Michelle. Yes, I have a note somewhere that said that. So that's fabulous. Thank you for capturing that. Okay, is there any other things we want to add to the letter, or any other final comments that committee members want to make today before we end our meeting, maybe even a few minutes early? Okay, I'm not hearing anything. Michelle, is there anything else that we need to do today?
Yeah, so we have a couple of closing slides, but one thing that we need to do is the main topic for the August meeting is going to be wandering, which is a topic that we've had as a potential agenda item for probably about a year now. And so we're looking for a few committee members who would like to help us structure that session in terms of what topics to cover and who to invite to present. So, I mean, we have some notes from prior discussions, but we'd like a couple of committee members who would like to help us work on that.
All right, do we have volunteers? Looking at you, Barbara.
Yeah, I already put it in the chat. I'm happy to help with that.
I knew.
More
you
than
were
happy to help with that.
That is great.
Claire has also volunteered in the room. So.
Oh, wonderful. Thank you. And if other people have some expertise they want to lend to that perspective or some personal experience that would be worthy of incorporating into the discussion, please either put your willingness to do that in a chat or let Michelle know. It'll be a great presentation, I think.
Yeah, I'm excited about it. And I think Rosie's going to pull up the slides again, just so we can do the last couple of slides with
That'd be great. Thank you.
Future meetings. So it's slide number 65, Rosie.
Okay, meeting schedule. You can, whoops. Went backwards, I think. Was it comments?
Next slide. There we go.
Okay, so these are our upcoming dates, August 1st, and then as we talked about earlier, we welcome all of you to come October 8th to the meeting, and then our last meeting of the year is in November. They're always in person in Sacramento, and you're welcome to join Michelle and others that are at the conference table in the meeting room Zoom. And otherwise, we can also participate by Zoom, but we'll look forward to seeing as many of you as possible on October 8th.
And
Okay.
Catherine, I think you and Lynn had discussed maybe, because I know this year we've been kind of encouraging members to attend particular meetings in person, and I know we did that in February. And I believe that you two had talked about maybe encouraging that for November as well this time.
Yeah, I think that's fine too. If people are able to participate in person, that would be great. I think I got a look like it's close to when we might be together, but we can certainly also do it in November if people are able to join in person. That's great.
Like Catherine said, I will always be here in the room and enjoy any company people would like to provide.
And she might actually arrange for lunch for you too. It's kind of cool.
Make sure you get food. Yes, Callie took great care of folks today.
Wynn, do you have any final comments?
No, thank you.
Okay.
A great meeting.
Yeah, thank you, everyone. Really a lot of good discussion, and we will see you. We will be together again August 1st, and hopefully see you all in October. All right, take care, everyone.
Thank you. Bye-bye.
Bye.